Dr. Sudhir, you can unmute yourself also.
Hi, ma'am. Good evening, all.
Yeah. Sharik, should I start?
No, ma'am, I'll just give you comment. You are live now, ma'am.
A very good evening to one and all of you for yet another very interesting ARC webinar. And this time it's a PG update series on corneal ectasia. And it goes without saying, with the kind of expert panel we have and a superb set of speakers and a great co-moderator with me, Dr. Radhika, it is definitely going to capture all the attendees watching now on much later on the YouTube or the ARC website. So we have with us Dr. Namrata Sharma, who is the professor of ophthalmology and a specialist in cataract, cornea, and refractive services, and an amazing honorary secretary of AIOS, and who has shown us that what it means to stand apart from everybody and do a great service to our country. We have with us joining soon Dr. Vanity, who is again a professor of ophthalmology, specialist of cornea, cataract, and refractive services from RP Center, and she's an ophthalmology of great reckon. And we have joining us soon Dr. Praveen Krishna, who's the director of the Cornea Institute and heads the refractive surgery, cataract, and cornea services from LV Prasad Eye Institute, and a dynamic surgeon with a great presence nationally, internationally. We have with us Dr. Sudhir, and I'm truly lucky to have him with us. Somehow he's been very elusive, and somehow I missed him in many of our webinars. Again, a senior, most respected cornea consultant from Shankar Nethralaya with expertise in ophthalmic epidemiology and corneal infections, a dynamic surgeon, and I'm sure he's a treasure to his institute as he is a treasure to our institute too. Don't ask me how. He has helped us out in so many ways. And again, the other expert panel with us joining shortly is Dr. Rajesh Fogla, who is again a senior consultant and director cornea clinic of the Apollo Hospitals, Hyderabad, an extremely versatile surgeon and a very gifted one at that in his great skill sets. Moderating with me is Dr. Radhika Natarajan, who's not just a great friend, but an amazing individual, Deputy Director of the Department of Cornea and Refractive Surgery, and also heads the Department of Teaching and Training in Shankar Nethralaya, Chennai, a very capable surgeon and a very informed individual. And I'm sure this webinar is going to be full of gainful knowledge at the end of 2.5 hours. Without any ado, we shall go on to our first speaker, Dr. Vini Joshi, a young consultant ophthalmologist from LV Prasad, specialist in cornea, anterior segment, and cataract surgery. And he is going to tell us something very quintessential to this whole webinar. How do we recognize an early ectasia, and what is the importance of refractive surgical screening? On to you, Dr. Vini.
Thank you, Dr. Chitra. Thank you, AIOS and ARC, for this opportunity, and I welcome all PGs on this session. So I would like to talk on this topic of early ectasia diagnosis with a very simplified approach. Just to go ahead with, when we talk about ectasia, what really comes out in your mind are the textbook terminologies, the paragraphs that go through our keratoconus, PMCD, keratoglobus, TMD, and nowadays post-classic ectasia. But reading that is different, but how to correlate those, its importance clinically, and how to tackle some of the questions that might come in the exams. It's interesting to understand this, the clinical approach in between. Post-classic ectasia has gained a lot of attention in the last few years. Although it was found out in some of the articles, its prevalence to be about 0.04 to 0.6%, but this is highly underestimated. And I think in the upcoming studies, we would find out that it's not so. And basically, it's a result of weakening of the biomechanical stability of the cornea as a result of any ablative procedures like LASIK, where we are giving a cut into the anterior 1/3 of the cornea. For an example, have a look at this case where the 23-year-old patient underwent PRK elsewhere, and he presented again with blurring of vision in the right eye. And you can see his anterior sagittal map towards your top left, that there is some amount of steepening that is ongoing in the somewhat inferior paracentral region. And you can also see a contralateral flattening there. This could be an decentered ablation, but if you correlate now that with the back elevation and the pachymetry, there is certainly definitely going wrong, something wrong. And the posterior elevation and bad display also highlights the pointers, where so it kind of ticks all the flag signs, and you should consider this as one of the post PRK or post refractive surgery ectasia. This is in the left eye. You can see that the sagittal map looks pretty much fine, and so is the posterior elevation bad display. These were the preoperative maps of the same patient, and you can see here what was missed in the axial sagittal curvature map is the prominent inferior and superior asymmetry. There is a difference of around almost 3 diopters of there, and I think that was not picked up, and this which was absent on the left side. So this case highlights the importance of screening of any case before going for any laser refractive surgery. Now, there can be 3 scenarios. First is that the cornea could be absolutely normal clinically, topographically, and then when we plan to take it for surgery, overall after some period of time, it manifests with ectatic changes. Second possibility, there are some preoperative changes which point towards a weakness in the cornea, and this biomechanical fragility is towards some minor topographic changes. And the third possibility is that where you have used a lot of ablation or where you have ablated a lot of tissue leading to weakness. The ectasia risk scoring protocol put forth by Randleman identifies topography as one of the most important factors. The anterior topography map, the sagittal map with inferior steepening is one of the most important risk factors. Residual stromal bed thickness to add to it, and age and high myopia happen to be other factors, where in younger age is a kind of a risk factor. And if you follow this particular chart, it kind of builds a map for you as to how many points you should look at when you screen a particular patient. An early ectasia where you miss out is the subclinical keratoconus, where either a form thrust or keratoconus suspect is something that you should look out for, and the telltale signs of the same, which are basically the early topography signs. Now, it could be inferior superior asymmetry, look for inter-eye asymmetry, steeper keratometry, against the rule astigmatism, and the front and back elevation maps, and look for red flags there. In tomography, newer technologies shows in bad displays, there are already flags placed based on the newer AI technologies, and posterior elevation, which is put forth by Bellin Ambrosio display, where you can see that I'll show in the next few cases how important that particular parameter is. Percentage tissue altered is one very important parameter. It was not included in the Randleman score, but I think it has a significant importance in cases which are normal to begin with, and a value of around 40% has a very good relationship between the biomechanical stability of the tissue, the thickness, ablation depth, and the flap thickness. And I think this is something which should be calculated in cases where you are anticipating larger, where there is a larger refractive error. This is one parameter you should always keep in mind. 250 microns as a residual bed thickness was identified in 1998 by Sealer et al. And there were reasons for the same, but now the recent study shows that this can vary up to 288 to 300 microns. So you have to watch for other signs that come along with it. It has to corroborate clinically with central corneal thickness as well. A typical clinical flag sign of less than 500 microns should alarm you to look for other signs. And other factors, which are chronic trauma, eye rubbing, family history of keratoconus, refractive instability, and preoperative best spectacle corrected visual acuity of less than 20/20. Now, what I would suggest is a fast check in a clinic is go through this in any patient. Look at the age. What is the age? Is it in early 20s or late 20s? Ask for eye rubbing and allergy. If the vision is not improving to 20/20 or N6, look for the asymmetry in the refraction, in the visual acuity. Look for the refractive error. What is the cylinder power? Is there asymmetry there? Then look at the maps. Look at the topography map first. Look at the sagittal, front elevation, back elevation. Look for the red flag signs. See the pachymetry then. And then if you have epithelial mapping, very well, good enough. And lastly, then look at the bad display. Once you follow this, you will never miss out at risk case. Look at this patient, 25-year-old patient came for refractive surgery, highly motivated. You can see here his refraction is again asymmetric. One eye is having higher cylinder power. And if you see at a glance, you can see that there is some amount of inferior superior asymmetry and some amount of steepness more in the axial maps on the right eye more than the left eye. When we probed the history of eye rubbing, he did give history of dust allergy, and as you can see in the bad display map, there is a significant posterior elevation, and we had to ask him to wait and repeat the scans after 6 months, avoid eye rubbing for the same, and he was advised against the refractive surgery at this visit.
1 minute remaining, sir.
Yes. Similar to that, this one case, again highlighting the importance of steep keratometries, thinner pachymetries, and telltale flag signs in the bad map. Now coming to this third case, you can see the refractive error is pretty high here, and the pachymetry is also well below 480 with inferior superior asymmetry, but the elevation maps are pretty much fine. Now, there is no posterior elevation. Now, this is a borderline case. Some people might want to go, some people might not want to go for refractive surgery in this one. But the inferior superior asymmetry is a little bit on borderline, and the pachymetry is well beyond 480. It's below 480. So that is the reason we didn't opt for surgery in this case. Another important finding, which I wanted to highlight, I'll put that in the last case. Some false positive cases are where we have seen that if the white to white is less than 11.2, and if the corneal thickness is more, you would not find any telltale sign in the anterior maps, but there will be some changes in the posterior elevation. Most of these patients actually do well after refractive surgery, and this is actually one of the false positives. I just wanted to add it to the list of the patients. So to just summarize, what I would again highlight is that you should take home is to look at this particular quick check in an OPD, which will help you to catch any case and review it in the clinic before you plan for any refractive procedures. Thank you.
Thanks a lot, Dr. Vineet. You highlighted all that was very essential and critical for us to know. Before I ask Radhika to take the next question, I'm going to ask Dr. Vanity. Would you, when everything looks okay on the topography, on the pentacam, but there is something which is there on the corvis, the red flags, would you attach importance to that? And then would you veer away from a corneal-based surgery and do a Fake Iul in this patient? Or what would you do?
Okay. I think this is the commonest dilemma which we always face, Dr. Chitra. And one thing which we have to bear in mind is the artificial intelligence software on the dynamic corneal imaging used the Caucasian data to establish its normatives. So I think applying it and extending it onto the Indian database. So we are looking at Asian eyes, and we know that our parameters would be slightly different. But that again is an assumption. Maybe it is not. But I would not, as a hard and fast rule, look at the corvis when it's red flagging. I would also look at the amount of red flagging and how it is based on, and in depth look at the various topographical indices, which would probably, give me an indication. Look at your apex positioning, look at the displacement of the apex positioning, look at your topographic mapping, look at your Kmax parameters in comparison to K1, K2. So there are certain fine aspects onto this. And always do explain to your patient that, the software is red flagging you. But upon a very extensive clinical examination, we feel that you could go ahead, but there is no 100% surety of how his or her cornea is going to behave, how his or her biomechanical strength is going to return following the healing process. So that's something which a clinician needs to approach in a case, as a custom approach or as a case-based approach.
So I'll ask,
Huh.
yeah, I totally agree. I'm going to ask, let Radhika take the next question. If time permits, I'll ask one controversial question.
Yeah, so this is an excellent topic, very well covered by Dr. Vinit, because our PGs, we get this as an exam question, and this is something that they will face in their future practice if they take up refractive surgery, how to screen the pre-refractive patient. So my question to either Dr. Vinit or Dr. Sudhir, who wants to answer this, would be that Dr. Vinit nicely elucidated the list of checklist. So it's not always black or white. If all the checklist points are okay, we proceed with the treatment. If many are red flag, then we don't do the treatment. But quite often in real life, we see that, one or two parameters are amiss, like, a little superior, inferior asymmetry, a little increased back elevation, all other parameters are okay. Having done it, you don't want to proceed either because these are fully sighted patients, but they're not so, off the target that you don't advise the treatment. So what do you do for those patients who have a few parameters which are red flag? Do you tell them no treatment, or do you wait it out to see how it would progress? What would you be advising them? Dr. Sudhir?
Yeah, basically whenever there are suspicious cases where we have one or two parameters which are not aligning with a thing, then what I would generally do is wait for 6 months or repeat the test and at a different day. The first will, so that if these are because of some intraoperative variations because of the examination, that can be nullified, and if these are not repeated again, then we can consider and give benefit of doubt to the patient. Other option is to wait for 6 months to see if there is a change in these parameters, and then if there are no change, then go ahead. And if still patient is very keen and if they are in borderline, I would go for a PRK with all these parameters kept in mind, so that we are not exposing the patient to more risk factors. So
Yes.
that will be my...
I agree. And if it were a Corvish having some of those minor red flags, the pentacam looks really neat and clean, then we would do a PRK extra for these patients. So that was my controversial thing. I do believe that, yes, PRK is the only possibility after following all the precautions which you did mention. But we've had very consistent good results with our doing a cross-linking combined with surface ablation. I don't see it makes too much sense if you're doing a LASIK extra, because cutting a flap in these cases makes absolutely no sense. But I don't know whether we have any other takers in this amongst the speakers, or Ritika, would you all be doing PRK extra in your center? Or Pooja, would you be doing it?
Ma'am, as you said, I definitely agree with you. If it has to be an extra procedure, it's always with PRK rather than the LASIK, because when you cut, you're doing LASIK, you're creating a cut of around 20 millimeters. Yeah. That itself is creating the weakening. So anytime PRK extra would be better in this kind of cases.
I think we'll go on to our next speaker and always come back to any of these challenging things. I mean, is Sahil, are you there?
Hi, good evening.
Hello. So I think you could start sharing your screen. Our next speaker is Dr. Vinit. You could stay connected and join in for the discussions. Our next speaker is Dr. Sahil Goyal, another very young dynamic ophthalmologist, consultant cornea and anterior segment, and a very dynamic surgeon, and senior consultant at Dayanand Medical College and Hospital, Ludhiana, and from a fellow from LVPI. And I'm sure he'll tell us exactly what we need to know about stages of keratoconus and management. On to you, Sahil.
Okay, very good evening. At the outset, I would like to thank Dr. Chitra and also her son, who has been helpful with the presentation for this evening. As I was seeing the program, we already have several talks on cross-linking, on topo-guided PRK, on Intex. So I'm not going to go into the details of various treatment options. I'm just going to help our residents and colleagues for the basics of management decisions. So when it comes to keratoconus, we have a multitude of treatment options, but do not get confused as to what is the best fit for the patient. The treatment algorithm is pretty straightforward and easy. And though the algorithm looks difficult and complicated, I'm going to try and decode it for everyone. First thing, when you find patient of keratoconus is for visual rehab, is the patient tolerant to contact lenses? But before that, please remember majority of these patients do have allergy, and sometimes when we are running behind vision and stabilization of keratoconus, we forget about the allergy. So treat the allergy first. Then for vision, see if the patient is tolerant to contact lenses, because no matter what you do, these contact lenses or rigid lenses provide amongst the best quality of vision and are the safest treatment options for these patients. The only time-tested thing more than 3 decades now. If the patient is not tolerating lenses or vision is not improving with contact lenses, then the next step you want to see is whether the visual axis is clear. If the visual axis is clear, then you would think of other options like surgical options. But if the visual axis is not clear, then you would think of corneal transplant. Before we go on further about visual rehab, let me classify the treatment algorithm into basic 2 categories. One is corneal stabilization and other is visual optimization. These are the 2 basic categories where the treatment should be focused upon. There are multiple algorithms available. Started in 2010, Dr. Narmada Sharma group, then 2015, Dr. Rohit Shetty. And these are multiple treatment algorithms, which might look slightly complex. But if you divide the management into 2 basic categories, that is corneal stabilization and visual optimization, things probably become easier. Okay, so if the visual axis is clear, then the next thing you want to find out what is progression. For progression, the basic treatment is cross-linking. Cross-linking may have many advances, but the problem now that most of us are facing is whether it is progressing or not. The decision making for the fact that whether keratoconus is progressing or not itself is very difficult. And like glaucoma surgeons have been struggling to define progression for glaucoma, probably in last decade with more and more technologies coming in, we are struggling to define whether the keratoconus is progressing. The variability of pentacam and all these new tomographers in advanced keratoconus itself sometimes might range up to 1 diopter, that sometimes we might get confused whether it is progressing. So grossly, most of the studies would take progression criteria as Kmax, K-mean increasing by more than 1 diopter per year, refraction cylinder increasing by more than 1 or 1.5 diopter per year, and third pachymetry decreasing, thinnest pachymetry decreasing by more than 5% per year. So if at least 2 of these 3 are present, and sometimes we also would like to emphasize on whether the patient also feels subjectively whether the vision is decreasing. Please remember, out of this, the subjective reflection is most variable, because every time you would try to do reflection for a keratoconus patient, the number of glasses would be very variable. Of late, for progression of keratoconus, we have new ABCD defined by Dr. Bellin. And let me come to that first. This is the new ABCD grading system. This was defined only in 2015. Before that, we had way old Amsler chromic grading system. So the ABCD grading system, in addition to the anterior surface, which was there in Amsler chromic, also incorporates the back corneal surface and the thinnest point or the pachymetry map. This is the first grading system which incorporates, in addition to anterior surface, the back surface and the thickness map. And then they have used this ABCD classification to determine whether the keratoconus is progressing. The D includes the subjective best corrected visual acuity also. So by taking various percentile scores and corroborating it with the Amsler chromic, they have divided various standard deviation cutoffs for stage 1, stage 2, stage 3, and stage 4. The A stands for radius of curvature centered on the thinnest pachymetry. You take just the central 3.5 mm zone centered on the thinnest pachymetry. Similarly, B, the radius curvature of central 3.5 centered on the thinnest pachymetry. The advantage of this grading system is when you're looking for progression, it probably would include your back surface and pachymetry also. The initial studies checking the validity of or reliability of this grading system for progression have shown that there is a very good true positive predictive value, though the negative predictive value is not very high. So if that says that it is progressing in any of the 1 parameters, probably go ahead and cross-link. But if it does not say it is progressing, you still need to find out with your older criteria of whether Kmax, K1, K2 are increasing by 1 diopter per year or the pachymetry is decreasing by more than 5% per year. But this is something that is new for detecting whether the keratoconus is progressing. After you have established whether it is progressing or not, then you finally decide about cross-linking. Please remember, the only exception where you do not really have to wait for establishing progression are high-risk cases, which includes number 1, pediatric population, mainly less than 18 years of age, Number two, people with borderline pachymetry of around 400, 420, because these are the patients where if you lose them and the pachymetry goes less than 400, you might not be able to catch again, except for the newer algorithms where by decreasing fluency, we are cross-linking corneas thinner than 400 also. And third is high-risk cases like Down syndrome or Leber's congenital amaurosis, where you know the child is going to rub the eyes, and or severe intractable allergy, where you know the child is going to rub their eyes and ultimately progress. So these three exceptions, you can cross-link immediately, but every other patient, irrespective of who has advised C3R, probably it is better to wait and establish progression before deciding for cross-linking. So we have conventional versus accelerated. In brief, accelerated initially thought to be equally efficacious. Now we feel that the faster we try to do, the less efficacious it becomes. The amount of flattening with accelerated decreases compared to conventional. Similarly, for Epi-on, though it is faster and safer, we try to use various techniques like higher concentration of riboflavin and ionophorosis, but again, the efficacy of Epi-on is probably lesser than that of Epi-off. Pulse is another modification which gives pulses of energy for oxygen replenishment. I'm not going to go into details of all these, including customized cross-linking, because this will be dealt separately. After you have established progression, you need to decide, along with cross-linking, whether you want to do CXL plus. By plus, we mean whether you want to add topo-guided PRK versus index. So if it is a relatively central cone, you would think of topo-guided PRK, provided the thickness is more than 450. The thinnest pachymetry is more than 450. But if it is eccentric cone or the thickness is somewhere, thinnest pachymetry is somewhere between 400 and 450, you would think of intax. Again, topo-guided PRK, I'm going to leave for the next presentation. The details will be covered, but the cutoff for topo-guided PRK is around 450, and for intax would be somewhere around 400. For decentered cone specifically, intax work well. The two things which we need to know about intax is that if it is asymmetric cone, decentered cone, then we need to give just one intact ring. And if it is a symmetric cone, then we need to get two rings. And also by increasing the thickness of the rings, we can account for greater effective error. If it is high myopia, you want to increase the thickness of the intact rings. So I'm going to defer these intact rings. Okay, so after index also, if you have specifically not cross-linked in the same setting, you also have the option of doing PRK later, further homogenizing the surface, followed by ICL if there is still high residual refractive error. For timing of PRK of C3R along with PRK delayed versus simultaneous, for PRK, probably most of us are doing simultaneous. For index, you can do simultaneous versus delayed with no definitive evidence of one being better than the other. All right, so this is about Fake Iuls. So cross-linking plus Fake Iul, again, you have to establish that the reflection has been stable. Fake Iul essentially will remove the spectacle, but will not improve the quality of vision, specifically the irregular corneal surface or the higher order aberrations. Final frontier, last option is corneal transplant. DAL, if there is extreme inferior thinning, you can think about Topographic keratoplasty. If you have, say, a rupture in this thing, or if it is high drops, you can directly take it up for an optical transplant. So I think that's where I would like to finish. Thank you, everyone, for your patient listening.
Thank you, Dr. Sahil. That was a very good presentation, and you highlighted what is essential for us in your talk. But a very question which I think I would want some of the expert panel to answer is, you see an early case in a patient in late 20s. What gives you the strength to say that you would observe the patient versus cross-link it? Whom do I ask? Dr. Sudhir, would you want to take this?
Yes, ma'am. The early keratoconus patients, I would like to watch, and patients who do not have a history of rubbing, and patients if they are good complaints to follow up. These are few patients which we can keep watch, and if basically those patients who are like in the or in the marital age group and we are planning for pregnancy, we should not watch. We should go ahead and treat them. Yeah. So this will be my take.
Yeah, that's what even I would have said. Radhika, you have anything to add on that? Or
yeah, so I am going to swing to the other extreme of the spectrum as compared to the one that you have mentioned. We have also seen that in some cases of very advanced keratoconus, where cross-linking is not possible, even with the custom protocol. But earlier days, we used to advise these patients surgery, either DALC or PK or whatever. But with the advent of the PROS contact lenses, especially in institutional practice, these patients many times get good vision because the fluid meniscus under the lens, it makes the fit easier. It gives optical clarity. So, you'll be surprised sometimes if the patient is reading 6.9 or 6.12. So my question to the panelists is that these people cannot be cross-linked, but they have excellent vision with PROS. And that is only the vision rehabilitation. The corneal thinning still remains. They may go for high drops at any time. So for the sake of vision, will you leave them with the PROS contact lens? Or even though they have good vision with PROS, for the sake of tensile strength, would you go ahead and do a corneal transplant in the form of a DALC? Maybe Dr. Namrata?
So, Radhika, I also similarly think the way, you've put up, and I think this is something which is really controversial. But I know that the assisted techniques of cross-linking possibly will not be 100% efficacious as the conventional cross-linking is, or maybe the accelerated cross-linking is. But I would still go ahead and do them. For instance, like contact lens assisted cross-linking has been described, and donor cornea assisted cross-linking has been described, and smile lenticule assisted cross-linking has been described. So I know that they are not as 100% efficacious. Contact lens assisted cross-linking is only 40% efficacious as compared to the conventional one. So we would go ahead and do it, and then possibly do a rose K contact lens fitting after that. Having said this, I think I must really congratulate Sahil for coming out with all the algorithms. I think it was a very nice lecture, Sahil, that you took all the algorithms which absolutely made it clear what to do when and what to use when. Another one thing only I would like to add, whenever it is a fellow eye of acute eye drops, then I think I will not wait for progression. I would just go ahead and cross-link.
Yeah. And besides, these contact lenses in these advanced cones has its own challenges. And if there is a worsening of the cone, then, fitting lenses, it's not a permanent solution. It's just a standby. So you need to keep your mind open to all the other options. You could buy time at the most. Dr. Sudhir, you have anything to add, or shall we go on further? You have to unmute yourself.
I agree. I agree. So nothing much from my side.
Yeah. So, and I'm very sorry, Pooja had wanted me to take her talk and then go on to the question, and I don't know how I slipped into
No, please don't.
So we have our next speaker, Dr. Pooja Kamar, who's a consultant in cataract and refractive services from Narayan Netralaya Group of Hospitals. And besides a clinical role, she's also very actively involved in translational research at her institute and beyond. And of course, she's one of those young dynamic ophthalmologists who has lots of awards to her attribute. So she is going to be telling us something more, cross-linking the cornea and what's new. So on to you, Dr. Pooja.
Thank you so much, ma'am. And thank you for giving us this opportunity, as I mentioned before, to present on this platform of AIOS ARC program. Sahil has made my job extremely easy by devising an algorithm of what procedure to do when it comes to keratoconus management. I'm just going to focus on cross-linking the cornea, what's new. Now, he's already highlighted that, whenever there's a progressive keratoconus, or wherever there is a pellucid marginal regeneration or post-refractive surgery ectasia, like Dr. Vini mentioned, these are the eyes that we would choose for cross-linking. This is a very simple algorithm about when to choose what type of cross-linking for the patients if they have progression or if they are in a high risk of progression, as Sahil already mentioned. So I'll just go into the details of the cross-linking. Now, the cross-linking has almost been there for more than 20 years now, and the journey started from the Dresden Protocol. What is Dresden Protocol? Dresden Protocol is nothing but it is to cross-link the cornea. Whenever the cornea is weaker, the collagen structures are extremely loose and they are not binded together, like how you can see here. But when you use riboflavin drops and UVA light, it makes your cornea stiffer and it increases the stress strain index of the cornea. So what do we do in Dresden Protocol? We use 0.1% riboflavin solution, 1 drop every 2 minutes for 30 minutes, followed by which we use ultraviolet light for 3 millivolts per centimeter square for 30 minutes. And that is how, and it is an epithelial off technique. You use it after removing the epithelium. And that is how the entire journey of cross-linking started. And it's still till date, a lot of surgeons across the globe feel that this is the standard of care when you are doing a protocol. But however, the journey did not stop here. Research went on happening, and then based on the Buskin-Rusko law of reciprocity, there were various protocols of 9 millivolts per centimeter square for 10 minutes, 30 millivolts per centimeter square for 3 minutes, 18 millivolts and 45 millivolts. This is the UVA radiation, what you give, followed by your riboflavin drops. And we did a study to compare all these protocols, and what we found was that the 9 millivolt protocol for 10 minutes irradiation time, where you give riboflavin drops every 2 minutes for 20 minutes, and during the irradiation time, you give it every after 5 minutes, works the best among this patient. So yes, 3 millivolt protocol is the best, but of course, the accelerated protocol of 9 millivolts has taken over. After that came the laser-based cross-linking, where the Cretans and Athens protocol came into picture. Sahil already has mentioned that you need to have a corneal thickness of minimum 450 microns to do a topo-guided PRK. Now, it's an entire lecture altogether of 1 hour, but I'll try to say what are the advantages of the topo-guided PRK. It makes your cornea, we all know that keratoconic cornea is irregular, but the TCAT makes it more regular and aspheric in nature, and it leads to centralization of the cone. It changes your refraction. It actually reduces your refraction, changes the Q value, and that's why the post-surgery quality and quantity of vision both is better if you combine your cross-linking with the TCAT procedure. You can do either Dresden Protocol or the accelerated protocol with your TCAT procedures based on the grade of keratoconus you have. And this is a published work that TCAT is an alternative effective modality of treatment in keratoconus versus cross-linking. Cretans protocol is nothing but transepithelial PTK followed by TPRK. You can or cannot use MMC, which is entirely up to your choice what to do. However, one thing you have to keep in mind is whatever happens, the ablation in your TPRK procedure should not go beyond 45 to 50 microns. However, it is not proven anywhere, but the ideal in a weaker cornea, you shouldn't go beyond 45 to 50 microns in addition to your epithelial removal. So these are the various laser-based cross-linking procedures you can do. You can do a topo-guided PRK using wavelight, or any other machine. You can do a corneal wavefront guided treatment, ocular wavefront guided treatment, or a TREC treatment, to which I will come on later on. Then a lot of people, of course, it is known that when you remove your epithelium and do a cross-linking, it is known to cause pain, irritation, watering, higher chances of infection. So it then came a protocol of epithelial on or transepithelial cross-linking, where you do the same procedure without removing the epithelium, but the riboflavin drops here would be different, mixed with dextran solution, tridoxymethyl-methane, and the EDTA solution, which loosens your epithelium and does cross-linking. You're not removing the epithelium, but you're loosening the epithelium so that the riboflavin can percolate in the stroma to make its cross-linking effect. The next would be the ionophorosis, where they make again, you do not remove the epithelial here.
You've got muted, Pooja. You need to unmute yourself. Unmute yourself.
So here again, you do not remove the epithelium, but you create a well of riboflavin, and with the ionophorosis treatment, which is the current treatment, the riboflavin percolates inside the epithelium, through the epithelium into the stroma, and the cross-linking effect happens. Then there is thin cornea protocols. Now, what to do? Initially, the results was whenever the cornea is less than 400 microns, the only possible option is the transplant. But now there are multiple other options of customized cross-linking, where the energy in the cone area is higher than and where in the areas where there is no cone area. And of course, the results are equally good as topo-guided PRK. Here, remember, you're not doing any laser. You're just delivering the energy in the zone of cone more than any other place. And that is why the cross-linking effect is better. As I said, the corneal transplant is not always the option. There are various treatments where you can cross-link. You do a small laser in the area of cone, which is known as the Prk procedure. You do not ablate the entire area, but just
what happened? Pooja, your presentation has gone and you are muted again. You have to share screen again.
Ma'am, just 1 minute. I think that is there. And then the hypoosmolar cross-linking, where you use the hypoosmolar drops for the cross-linking effect. Then in pachymetry less than 400 microns, you can use a lenticule of a smile procedure or from your cornea stroma, through which you put the riboflavin drops and the UVA light. It will reduce the damage to the endothelium. The second procedure is the contact lens for assisted cross-linking, where instead of lenticule, you put a contact lens on top of the cornea, through which a contact lens is soaked in the riboflavin drop and through which the UVA light is delivered for the same effect. Professor Farhad Hafezi et al. And our group has devised this calculator where you remove the epithelium, and based on the corneal thickness, you calculate the energy, what should be delivered according to the corneal thickness based on the 3 millivolts or the 9 millivolts, which should be delivered to the cornea. Basically, here you're just adjusting the fluence depending on the corneal thickness. So even if your corneal thickness is less than 400, 390, you can still do a cross-linking for this patient. So to summarize, there are various cross-linking procedures available in our armamentarium. Dresden Protocol, of course, is the best, but you can choose your patient and opt for a accelerated cross-linking or a hyperosmolar cross-linking or a customized cross-linking as well. Thank you.
Thank you, Dr. Pooja. That was a...
Thank you, ma'am. Sorry for the technical glitch.
That's okay. So I see Dr. Praveen has joined in, so I'll ask this question from him. Now, Dr. Praveen, does endothelial damage occur with cross-linking, or is it that the endothelial cell count is apparently low more because of the hairs and the scars? And is this value of 5.4 really a problem, or is it really a danger?
Hi, Chitra, and again, apologies for joining late. But then again, I caught the last part of Pooja's talk, but thanks for that question. It seems that in keratoconus, the endothelial cell counts are normally low because the surface area of the posterior part of the cornea is more, and you know that the endothelium is finite in number. So they stretch to accommodate, and the endothelial cell count has been known to be low. In cases where you have splits in the desmoid membrane, and it drops precipitously because they again tend to migrate. But from the perspective of collagen cross-linking, though it has been shown to be endothelial toxic, most protocols ensure that the cross-linking is delivered to a depth of about 300 microns. And so you have about a 50 micron safety limit from the endothelium. But even if you actually cause localized endothelial damage, most of these corneas are quite healthy, patients are young, and if you look at the alternatives that the patient has to face, it probably is still justified to go ahead with cross-linking because of the fact that most of the endothelial damage, if it does, will happen only in the area where the thinnest part of the cornea is present, which is a very small area, and the rest of the cornea will not be affected. So it still should be okay.
Dr. Radhika, your question?
Yeah, so that was a very comprehensive presentation by Dr. Pooja. And just to add to Dr. Praveen's comment, there is a rare but sure entity where Fuchs and keratoconus coexist. So we need to include specular microscopy and looking for Goutet changes as a practice when we screen keratoconus patients for any treatment. But my question is probably to Dr. Vanti, because I have seen her, talk on platforms with her elegant stepladder pattern of management of keratoconus, always caught my attention. So what I want to ask you is, there is a small but sure segment of patients, Dr. Vanti, who progress despite cross-linking. It's documented in literature as well. but literature is not that abounding with data on repeat cross-linking. So when would you do the repetition of the procedure? What would you be thinking as criteria for that? And have you had success with repeat cross-linking?
Okay. Yes, Dr. Radhika, I agree with you that we do see a small subset of patients who would progress even with cross-linking. More of these patients are pediatric patients or pediatric keratoconus, and more of them are those with chronic VKC patients here. And again, I do not, I think it's beyond my understanding why that these patients are progressing. And I think it has been described and debated in several platforms that in pediatric keratoconus, the effect of cross-linking is perhaps staying on for about, say, 3 or maximum 4 years. So beyond which you would probably expect some parameter of thinning in these patients. But we do see certain controversies in the fact that the imaging itself is not something which is, similar when you do the intra-observer and inter-observer variations with our Schrein flux imaging is quite high in cases of keratoconus here again. So I per se have not yet done another enhancement of collagen cross-linking, and I would like to hear the opinions and experiences of the others in the panel. So that's something which I cannot throw more light upon. But these are the pediatric keratoconus patients who are probably cross-linked early on, 3 to 4 years down the line of their first cross-linking, more so in patients where there is an ongoing inflammatory process of chronic VKC are going to be the most liable group.
Correct. They are at highest risk for progression despite cross-linking. Anybody in the panel has experience on repeating the procedure in the size of the tumor?
If I can just talk on this.
Yes, Dr. Namrata.
We did a prospective study of 116 eyes with pediatric keratoconus, and this is published. So half of our patients required collagen cross-linking. 1/4 of the patients were rehabilitated on contact lens and glasses alone, and 1/4 of the patients were severe enough to require deep anterior lamella keratoplasty or penetrating keratoplasty. Now, our rates for repeat cross-linking are close to 10%, and because we had undertaken accelerated collagen cross-linking in all these eyes, when we did a repeat collagen cross-linking, we used the Dresden Protocol, because I do feel that accelerated collagen cross-linking probably is not the way to go, especially in case of children. And they are better treated with Dresden than with accelerated. Although, if you look at the other side, cooperation would be more because the time would be less with the accelerated protocol. And like Vaniti said, 3 to 4 years, sometimes 6 to 7 years also. But I think that also occurs. It was also found to be more in those cases which had VKC. So probably the eye rubbing part doesn't stop in them, and that is why also this leads to, failure of collagen cross-linking and progression, despite the fact that you have cross-linked them. But because the turnover of the collagen is in that same period, 6 to 7 years is what they say is that collagen turnover. So that is why possibly the failure occurs during that time, or time which is little less than that, 3 to 4 years.
Once the new collagen comes, then the effect goes up. Thank you, Dr. Nam.
Dr. Praveen, you have anything different to add to this, or shall we go on to the next one?
No, I agree with what Namrata said. Thank you.
One small thing I would like to share is I have 2 cases. One was a 15-year-old boy who was done first C3R in around 2014, and 5 years down the line started progressing. I did a repeat C3R in 2019, and last 3 years at least he has been stable. After the first C3R, there has been documented a demarcation line at more than 300 microns depth, which makes me question how effective the depth of demarcation line is. But after 4 or 5 years, there was sudden progression in at least one eye, and last 3 years at least it has been stable. Second case I would like to share is post Athens protocol. So I started Athens protocol only after the 10-year follow-up results were published by the Cancolic group. And seeing that the cornea was stable for 10 years, I started doing a topo-guided PRK plus C3R. But out of the 10 odd cases, at least one has progressed within almost 6 to 9 months after surgery. So which makes me question whether the thinning, iatrogenic thinning we are doing in these patients along with the cross-linking, how really safe it is. So luckily that girl, when the mother was behind me, that, you thinned the cornea further and that has led to the progression. I said there might be some other risk factor, and I asked them to get an ultrasound done if there is PCOD or something. And she turned out to be PCOD positive. I'm not sure how big a risk factor that is, but at least that helped me get the mother off my back, that you are responsible for the progression.
Yes, yes, definitely food for thought. Thanks, Sahil. And we
Can
shall
I
now
just add one point?
yes.
Yeah, one more thing is very important is the Dexterity Protocol, the riboflavin, which is with dextran, shrinks the cornea too much during the procedure. Yeah. And when we started using HPMC based, the cornea swells up. So we we can do the cross-linking in a more wider range of thickness of keratoconus. So only thing we need to know when we do with HPMC based, the demarcation line will be more anterior compared to the Dresden Protocol. So we need to look into the studies comparing these two. That's one thing. And long term, we have also started seeing significant flattening and thinning of these corneas when they are about 10 or 15 years. But their vision is very good. Because of the flattening, the vision is extremely good with the spectacles. But only thing, we need to keep a watch on the thinning. So on long term, more than 15 years, the corneas are like around 300. So one need to be watchful of this again. Thank you.
Yes, yes, yes. Thank you, Dr. Sudhir. We shall now go on to our next speaker, Dr. Sanduriya, who is a consultant at the Eye Foundation Group of Hospital based at Coimbatore, and again a consultant in cataract cornea and refractive surgery, a very dynamic young ophthalmologist, and I see a great future for her. And she is going to be dealing on topo-guided treatment, a major aid in visual rehabilitation. On to you.
Very good evening to all the respected panelists and speakers. I'm very thankful for Dr. Chitra ma'am for giving me this opportunity. So after this extensive discussion on cross-linking and the various indications for treatments in keratoconus, I would like to talk about a few points about the topography-guided treatment in keratoconus and how and why it works in visual rehabilitation in these patients. So as we all know, cross-linking prevents the disease progression, but the patients are still left with an irregular cornea, and that is filled with aberrations, and which thus decreases the visual quality. So that is where topography-guided treatment comes into play. The idea of topography-guided treatment is to transform the focal steep cone into a flatter, broader cone, thus creating a more uniform refractive surface. So this is achieved by creating a myopic ablation at the apex of the cone in the center, which causes a flattening, as we can see, and a mid-peripheral arcuate hyperopic treatment, which helps in steepening the flat cornea anterior to it. So what are the preoperative requisites? As it has been told, a minimum preoperative corneal thickness of about 450 microns is required, or in other words, an intraoperative residual stromal bed following ablation and epithelial removal of 350 microns, or a postoperative thickness following the reepithelialization of 400 microns. So does it mean that in any patient with less than 450, we cannot go ahead with topography guided treatment? No, we can go ahead, but we need to keep in mind that the postoperative thickness does not go below the recommended level of 400 microns. And the ideal candidates are those with mild to moderate keratoconus. And coming to timing of procedure, definitely when combined with the topography guided treatment, the simultaneous procedure does have advantages over sequential procedures. One is the reduced time away from work for the patient, of course. And the second point is the possible reduction of haze that follows when combining it with the topo guided PRK, because cross-linking induces a keratocyte apoptosis, which thus reduces the number of migrating fibroblasts, which are the main reason for the haze. And also it helps in enhanced penetration of the riboflavin into the stroma. And as has been told, the conventional versus accelerated CXL, that is a 9 milliwatts per 10-minute protocol, has shown to cause a lesser amount of haze and a lesser flattening effect. And when it comes to keratoconic eyes, we know that there is a variable epithelial thickness that is thinner over the apex and thicker over the base. So in manual debridement, we're going to be variably removing the epithelium. So the final surface that we're going to be treating is going to look quite different from the surface that we have preoperatively measured. But in PTK, when we're doing a phototherapeutic keratectomy, there's going to be a uniform tissue removal throughout, which is going to result in a surface which is going to mimic more closely the surface that we have measured using the topalizer preoperatively. And when coming to planning, here we need to remember that the idea of a topo-guided treatment is not a refractive error correction, but it's just for the regularization of the cornea. So here we tend to bring down our optic zone to 6 mm or sometimes even 5.5 mm in order to save tissue. And the maximum amount of tissue ablated, we try to keep it below 50 microns, but there have been studies which have gone up to 80 microns, and provided that a good amount of tissue is available. And a minimum of 6 repeatable good scans are required to proceed with the planning. Just a few words regarding the steps of planning. This will be the first screen that we'll see. So the exported scans from the topolyzer are seen here. And what we need to note here is the mean deviation has to be kept within 0.1. That means the scans have to be more similar to each other. So when the mean deviation values are higher, we tend to go and remove any outlying scans so that the final value of mean deviation comes below 0.1. Once this is done, the next step is to enter the manifest refraction along with the pupillary diameter and the corneal thickness in the center and the 6 mm zones. First, by making the modified refraction as 0, what we're going to be seeing is the basic ablation profile that the machine is going to be doing in order to regularize the cornea. So as we have told, the myopic and the arcuate hyperopic ablations that are going to be done. And we're going to be noting the amount of tissue that is being utilized for the same. So here we can compare this with the axial sagittal curvature map of the pentacam, where we can see the steepest area, there's a myopic ablation, and the mid-peripheral arcuate ablation is also going to be noted. So after we note the amount of tissue that is used for regularization, then we can plan for the refractive error debulking if the tissue is available. So here first we're going to maximally debulk the cylinder as much as possible, following which we can go ahead and correct the refractive sphere. So when we're correcting the refractive sphere, we need to remember that we're going to be undercorrecting the refractive sphere in order to compensate for the flattening effect of the cross-linking. Although accelerated cross-linking has shown to cause a lesser flattening effect, we tend to undercorrect the sphere at least by a 0.5 diopters. So here, this is one of the simplest cases to plan because the refractive cylinder, the magnitude as well as the axis are correlating well with the manifest refraction of the patient. So here we can go ahead and plan as given. However, in more irregular corneas, we tend to see that the measured cylinder is going to be quite higher, and as well as the axis is going to be quite different. So in these cases, unlike the contour planning that we do for a refractive correction, here we tend to go more towards the topographic axis as well as the magnitude of the cylinder, because the idea is to regularize the anterior surface of the cornea. So if the refractive cylinder of the topography is higher, we tend to go correct higher than the manifest refraction as well, and also with the axis. So to confirm the axis, we can also compare it with the front elevation map of the pentacam. As we can see here, both these maps correlate well. And here another point to be noted is that we've gone down with the optic zone in order to reduce the tissues consumption. The example showing the outcome. So we can see that the topography has regularized quite well, and the uncorrected as well as the best corrected visual acuity have increased, and there is quite a significant amount of debulking with both sphere and cylinder. So just two maps that I wanted to show where we need to be a little more careful in planning are these maps where there is a significant amount of asymmetry, extreme asymmetry around 10 diopters, and there is a flat K reading in the center. So in these kind of patients, as we can see, the arcuate hyperopic correction is going to steepen the flat area that is seen centrally. What this will result in is a myopic shift for the patient. So in the patient who had just a 0.5 hyperopic correction has resulted in a minus 3.25 diopter sphere. So although the visual quality or the BCVA improves in such patients, the uncorrected visual acuity may not, and we need to explain this, and this shows the importance of the need for patient counseling preoperatively, and to explain to them that what we're doing is not for a spectacle-free vision, it's just for improving the quality of vision. Another tissue-saving measure is adding a hyperopic error when the patient actually accepts a hyperopic error. So as we can see here, when we're not adding the +1, the tissue consumption is around 59 microns. Whereas when we go ahead and add the +1, it reduces to 51 microns. So comparing between centered and decentered cones, the effect of final visual outcome has been shown to be good. However, the uncorrected distance visual acuity has been found to be better with centered cones. Just an example of a center cone where the BCVA was 6.9 with a 3.75 cylinder, which improved to 6.6 with just a 0.5 diopter cylinder, and you can see a beautiful regularization in the topography. And a decentered cone here, we can see the more than 50% of the points lying outside the 3 mm zone in the back elevation map. With a BCVA of 6.9 and a 3 diopter cylinder, patient ended up with a plano 6.6 vision. Use of mitomycin C, as has been discussed, has conflicting views because Quinones et al. Had shown favorable outcomes even without mitomycin C. However, we still continue using intraoperative 0.02% mitomycin C for about 20 to 40 seconds. And stability, Kanellopoulos et al. Have studied the 10-year outcomes of keratometric and visual stability, and they've shown that only 3.5% of the eyes have shown progressive flattening or a hyperopic shift. Another new arena that can be that has shown early good results is the customized cross-linking combined with topography-guided treatment. The other uses of topography-guided treatment in other irregular corneas like PMDs and iatrogenic classic ectasias have also been good. And in other cases like decentered ablations, small optic zones, and post-PK and RK eyes, also topography-guided treatment can be used. Just an example of a post-classic ectasia with a highly irregular cornea, as we can see. So there's a beautiful regularization, and the patient's BCVA and UCVA have improved quite well. So when combined with cross-linking, apart from arresting the progression, topography-guided treatment definitely aids in patients, especially with early keratoconus, early to moderate keratoconus, to give them some degree of spectacle independence, as well as improving the visual quality and the best corrected spectacle visual quality in these patients. Thank you.
Yes, that was a wonderful talk, Sanduriya. So I'm going to ask this question to you because I know how intensely involved you are in the planning of these cases. How would you deal with a hyperopic shift following a topo-guided PRK? Would you give us some tips how to prevent it?
Ma'am, initially to prevent it, basically the planning has to be done well, ma'am. So the main idea is as I've told, when we debulking the cylinder, we need to keep in mind that we're not going beyond the spherical equivalent or the refractive spherical equivalent of the patient. So if we're going to be overcorrecting it, definitely a hyperopic shift can be expected in such patients, ma'am. So that is something that we need to keep in mind.
Or sometimes if it is haze which is causing all these issues, sometimes
and the long-term steroids can also be given.
Yeah. And one controversial question before I ask Radhika, what are your thoughts of topo-guided PRK in pediatric AC? I did hear what Sahil had said. Would there be a small segment where you would consider doing a topo-guided PRK in pediatric AC? And who are the other people on the expert panel who are doing topo-guided PRK? Dr. Namrata?
Yeah, Chitra, I think it was a very nice talk. It is a difficult topic.
Yes.
Not very many people venture it. Not very many people are convinced about it. But I think Sanduriya showed very good pictures, to actually, which can convince people that it does work and we should do it. In children, we've not tried to do it, and hyperopic shift is a reality, and I'm glad that you brought that out. I don't know how it will work out in children because everything tends to be a little more unpredictable, and we've not done in any children. I don't know if you have done any, and if anybody else has done and would like to share the same.
Yeah, no, I was just wondering whether in a younger age group, when there is a compromised BCVA and there's a possibility of amblyopia getting more, would that be an option when you could do a small amount of regularization of the topography with cross-linking? Anybody on the expert panel have something to add about this, or it would remain a question?
Can I add
yes.
something?
Yes, Dr. Praveen.
So, I think, like we discussed in the previous talk, and we were speaking about how children are more likely to require repeat cross-linking than adults.
Yeah.
And also because the time to potential progression is longer. Like say if you're doing cross-linking for a child and you're likely to be requiring a second cross-linking, I think from that perspective, it is important to avoid doing a PRK in anybody who might require a repeat cross-linking, at least from that perspective.
Yes, agree. Yes, definitely an answer. So anything else, Dr. Radhika, would you like to ask?
So as a continuation to the answer that Dr. Praveen gave, I have another question for him or the others, that if you did a TGPRK, we know that well established among ourselves now that there could be progression after cross-linking, especially in the younger age group. So if progression did happen after TG-PRK, then would the indicators be the same or different that we use for conventional, non-topography guided cross-linking? How would you pick up progression after TG-PRK?
So Radhika always, makes us think more, and I completely agree with this. I never thought that this would be, the parameters would need to be different, but I think you are quite right. The parameters for virgin corneas and for TG-PRK corneas of keratoconus would possibly need to be different, and maybe you would also need different devices for them. Even for repeat cross-linking in children, when you say we are actually only based on Schemflug or Pentachem, but I think you would need something like a MS39, because after collagen cross-linking, there's a little bit of haze, which the Pentachem gets fooled by, but MS39 will not get fooled by. So I think these are issues which will remain and which would need to be sorted out.
Also, I would feel that in that case, a holistic perspective of, the history, the patient's vision with contact lens, subjectively what the patient feels, everything put together along with the imaging, and like Dr. Namrata rightly said, what's happening below the epithelium at the Bowman's level with an imaging device would give a better clue as to whether the disease is stable or not once we've surgically. Thank you.
Yes, thank you. So we shall now go on to the next speaker, Dr. Ritika Sachdev, again, a senior consultant and actually an additional director, the medical services at the Center for Sight Group of Hospital, who's a cataract, cornea and refractive surgery as a specialty, and is doing an amazing work when you see the wonderful growth of Center for Sight as a whole over the entire country. And she is going to take us on to intracorneal ring segments, current indications and techniques. So let's hear from her.
Thank you, Dr. Chitra, for this opportunity. I'll be talking about our experience with intracorneal ring segments. These are basically tiny arcs of PMMA which are implanted in the cornea. They were originally designed to flatten the cornea to treat myopia, but there, of course, the excimer laser did a fabulous job. And because this was a tissue additive technique, its use got translated to corneal ectasia, wherein you are dealing with a weaker cornea and you would prefer not to subtract tissue, but to add to the tissue. So various ICRS segments are available. The intact segment is what we have used frequently. Now, of course, you have biotech coming up with its own segment. You have the Ferrera rings, the Kera ring segments. The things to remember about these segments is that they vary in thickness and in cross section and in the place at which they are implanted in the cornea. The closer they are to the pupil, the more effect of flattening they will induce, but also then they will have unwanted photic phenomena, which is taken care of by choosing an appropriate cross section to minimize the glare and other such side effects. The thicker they are, again, the more will be the effect. So the thickness and the area of implantation and the cross section are important criteria which you should review depending on the segment that you are looking at. These segments basically work in spacer devices. Now you can see when you put in a spacer device, you're basically shortening the arc and therefore flattening the center. This cone obviously is a bulging area and flattening it will functionally improve the vision. But where the ICRS segment score additionally is that there is a stress or a biomechanical stress that is induced in the cornea, which leads to progression of these cones. What the ICRS segment does is that it redistributes the stress, and therefore, in cases such as post-classic ectasia or in cases where you feel that the keratoconus is progressing despite cross-linking, this is an additional tool because it will redistribute the stress forces and possibly has a role in delaying the progression of keratoconus also, in addition to the functional benefit that it will provide by flattening the cornea. Now, these are the indications that we use in our practice. I feel this technique works very well for patients who are contact lens intolerant or who have ectasia in one eye, because they see well with the other eye and therefore do not have the inclination to continue wearing contact lenses just for improving one eye. Contact lens fitting after ICRS is a little tricky, though some people feel it's not. In my practical experience, it is tricky. So if a person is doing well with contact lenses, I would not venture in for ICRS so easily. The patient should have a central clear cornea and a good thickness at the site of proposed incision, that is at whatever zone that you are implanting, which may be different for different ICRS. 450 was the cutoff for ICRS of intacts, but various other rings may have different cutoffs. And obviously, you are sparing this patient from a corneal transplantation option. The plan requires you to do a good topography and based topography preferably, and also do a good refraction. We try to base the planning on refraction more than topography if the refraction is reliable. That means the steep axis is defined basis the refraction. If the refraction is reliable, if you feel the refraction is not as reliable in case of poorer vision, then you go on to the topography map. Please note that, like has been mentioned earlier, this is a good modality for eccentric cones and for moderate cones. If a patient has vision of 6/9 or better, ICRS is best avoided because it is not fully mathematical. It is more an art than a science, and patients with vision better than 6/9 may lose vision also. Now let's plan the ICRS segment. Refraction is important because more is the bulge or more is the refractive error, the more is the flattening you want to do, and therefore you use a thicker segment. Like Sahil pointed out, for eccentric cones, that means which are where the posterior float is outside the 3 to 5 mm zone, there you will need asymmetric or single segments. And for more central cones, you will flatten it diffusely. You don't want one-sided, lopsided treatment for a symmetric cone. So you're going to use a symmetric or two equal segment for this central cone. The incision is planned on the steep axis, like I said, which should be defined by refraction. If refraction is variable, then go on the basis of topography. We use the femtosecond channel to create these channels into which the ICRS is inserted. This is an example. The patient has keratoconus, and this is the refraction -1.5 sphere with a -3.75 cylinder. Remember, the refraction has to be transposed to a positive cylindrical form. And then if the cylinder is more, you're more likely to deal with an eccentric or an asymmetric segment requirement. And if the sphere is more, it is more likely a symmetric segment requirement. Right? So here, once we transpose, if the sphere is more, so we are going in for symmetric segments, the thickness of which depends on the quantity of flattening or the spherical equivalent. And this is the patient post-operatively, and this is the difference map, which shows an improvement in topography, refraction, and PCVA. Similar case of KC, but this is again an eccentric cone. And you have a cylindrical component which is much higher than the spherical component. Therefore, either you go in for a single segment or asymmetric segment with a thicker segment in the area where the cone is larger, that is the inferior segment, most commonly being thicker. This is the patient and the difference map, which shows an improvement up to 6.6 also. We normally combine the ICRS with cross-linking because we do it in a simultaneous sitting. It gives you a single stage procedure. It also allows increased cross-linking of the channel because the riboflavin pulls in the channel, and the cross-linking of the channel is supposed to enhance the effect of the ICRS. You may, however, do the ICRS first and the cross-linking later also, but not the reverse way. Because once you are regularizing the cornea with the ICRS, it is post that you would want to freeze it with the CXL procedure. This is a patient who had simultaneous CXL and ICRS. This is the post-operative outcome. You see that the astigmatism has fallen from 5.4 to 1.1. So the results are often very gratifying. This is another case where you see this is the post-LASIK ectasia. This is a case which does not respond very well to CXL at times because the LASIK flap getting cross-linked, possibly the anterior effect of cross-linking is more, and therefore the end result of cross-linking in post-LASIK ectasia is less than that in keratoconus. And here the ICRS is a very useful tool, and we do ICRS in most of our post-LASIK ectasia cases. And this is the improvement in vision. Like with any procedure, it does come with a share of complications. However, the cornea is a very forgiving tissue. This is a patient of ICRS where there is a white cell reaction. So there is some dead space along.
You have 1 minute remaining, ma'am.
So this is a white cell reaction. Do note that around the tunnel, you sometimes have lipid and calcium deposits also, but white cell reaction will be accompanied by symptoms and congestion. And this is important to treat with steroids because this prevents an extrusion or a melt of the cornea. This is a patient who's had a melt after many years of ICRS. You avoid a melt by making sure that the the proximal segment is at least a millimeter inside the incision. We also suture the incision and remove the suture after about a month. But in case it is extruding, you have no option but to remove the ICRS in such a case to prevent further melting, because it sets in a vicious circle of melting. The epithelialization doesn't happen over the PMMA segment. So this has the segment has been removed after many years. Fortunately, the flattening persisted because the cornea had remodeled and there was scarring around the tunnel, and that possibly led to a perennial effect of flattening and remodeling. So this is a very rare case of a femtosecond assisted channel led to a perforation, but again, you simply remove the ICRS and the cornea, being a forgiving tissue, recovers back very well. So all in all, I'd like to conclude by saying that ICRS, being a tissue additive technique, is a predictable option for functional improvement in patients with corneal ectasia. We recommend it as a simultaneous single procedure along with CXL. Complications, though, are few, but they are very easily manageable, and patients are often very happy with this. It's chosen for the right case. Thank you for your attention.
That was a wonderful talk, Ritika. So before I take the question, the expert panel, I'm going to ask you a question. Do you feel the intacs being placed in a post-cross-linked eye at a later date, how effective it has been in your hands?
It is definitely less effective post cross-linking, and actually the perforation that we had was also post cross-linking, because we don't know whether the haze altered the femtosecond pass or not. So we had this consideration of the femtosecond laser channel also being tougher to create, the insertion becoming tougher, and don't know whether the perforation was related to that. So the intraoperative section may also be tougher in certain cases, but usually cross-linking is in the anterior part and the channel is posterior. So I personally have not had much trouble inserting it post cross-linking. However, the effect is less. So I would opt for a thicker segment post cross-linking.
Dr. Praveen, I have this question for you. What is your cutoff when you would use a single segment and when would you use asymmetric segment? And
even before answering that question, I think my tolerance for intacs has gone up quite a bit. So now I prefer that if somebody is suitable for TPRK with cross-linking, I would prefer to do that, because I think you would control the result more or more accurately than with intacs. Intacs is a bit of a hit and miss in some cases, and great talk, Ritika, and you'll sort of agree with me as well.
Yes.
But again, from the perspective of whether to sway in the intacs direction or TPRK, again, those corneas that have more asymmetry, I don't think I put a number to it or a value to it, will benefit more from intacs as compared to those who have symmetrical cones.
yeah.
So symmetrical cones probably more TPRK or just PRK by itself, whereas asymmetric cones intacs followed by cross-linking.
Yeah, I think also if it's a more of a localized astigmatism, then the single segment, and if it has got associated with a spherical equivalent being higher, then I think asymmetric segment could also be thought of. Though I think largely we seem to be doing more of single segments now with a very significantly good result. I'm sure that must be the same all over.
I think intacs has found a lot of flavor in post-classic ectasia in everyone's hands, because there it is a very useful tool. Cross-linking is less effective, and in post-classic ectasia, most of us are actually doing single segment because it's an inferior ectasia, and that remains a very common indication for ICRS.
Yes,
Dr.
Radhika?
Ritika, yeah, that was an amazing presentation, Dr. Ritika. I think it's one in which you power packed all the points in such a short time. Truly we went through the gamut of how to select, what to select, and what to expect. So the only question I have for you before moving on is that we know that many keratoconus patients have a background of allergy. We won't do any of these procedures unless allergy is under control, because then we could have recovery or healing issues. So if a patient has a background of vernal, would that affect your decision of doing intacs? do you think that the complications that you showed earlier, like inflammatory cells or white cells, or even a melt over the intact, may be influenced by taking in a patient with a background of vernal catarrh?
Absolutely, I think it's something very important. Even for cross-linking, we see sterile infiltrates more. The risk of progression even in cross-linking. So I treat VKC before any procedure. For intacts, not only does the VKC increase risk of corneal melt by itself, the eye rubbing itself also is predisposes to a melt. So both are very important. You want to treat the symptoms and the inflammation both significantly. And the white cell reactions that we see are more common in younger individuals who have VKC, and these are the ones which later lead to corneal melt. So we definitely we look out for the ocular surface both before cross-linking and after before ICRS.
So that's the message I wanted the PGs who are listening to get, that not to just get carried away by the maps and the surgery and the glorious result, but most of the hard work lies in selecting and preparing the patient for these procedures, which then defines the outcome. Thank you so much. You put it across it again.
We shall now go on to our next speaker. Thanks a lot, Ritika. That was an amazing talk. Our next speaker, Dr. Sanjay Chaudhary, who's the founder and director of the I7 Chaudhary Eye Center. He's a leading cataract and refractive surgeon, and very much in the forefront when it comes to surgical and technological innovations in eye care. And he's just the right person to tell us about faking intraocular lenses in corneal ectasia. On to you, Dr. Sanjay.
Thank you, Dr. Chitra. So my role comes in after the corneal people have done their job for ectasias. Now, as a first procedure or a second procedure or a third procedure comes the role of faking intraocular lenses. And why they prefer to send them to me in some situations is because they want somebody who has a lot of experience with faking IOLs and who can deliver very precise access for placements. So when I talk about faking IOLs, I would say the requirements would be that the lens should be such that it can correct very high myopes at time, even up to 24 diopters, can correct very high cylinders at time, even 10, 11, 12. So the lens has to be customizable and easily available. There should not be an extraordinary waiting time. By default, I use the star ICLs, but the star ICLs have a limit. They are limited that the maximum myopia manufactured, correction manufactured is 18, which corrects a myopia of 17.5. And the maximum cylinder which is manufactured on their lenses is 6, which corrects a cylinder of about 5. And if there is a combination, then if I'm using a 6 cylinder, my myopia correcting ability would go down by 6. That means I would be correcting 12 of spherical myopia to keep my 6 cylinder active. So I need a lens which has greater flexibility, more range. So many a times I use the biotech phakic IOL. With this, I can go up to 25, 26 of myopia. I have used just recently, about a week back, a cylinder of 11, and the lens was made available to me in just 5 days' time. So it's a big advantage to have both these lenses in your armamentarium. And the second thing which is very important is when you're dealing with such high access, you have to be bang on accuracy when you place the ICL or any phakic IOL in the eye. So, because in most of these situations, or in many of these situations, the cylinders are very high, and even if there's a 10-degree variation, then there would be a loss of 10%, or sorry, it should be a loss of 30% of the cylinder effect. So I stand corrected here. Read this as 30%. So if the situation is that there is a 9 cylinder which needs to be corrected, it will lose 3 cylinder value if there is a variation in the axis which is off by 10 degrees. And that becomes very significant. So how can we overcome this? So we need a system which is a little beyond a manual bubble marker system or a slit lamp system. And this would be a digital access marker system like the Varion. And we find it very useful and really accurate at times. However, there is a negative side to it that in such high cylinders, many a time the Varion data is not captured and we again have to depend on the manual system. And if it is a manual system, I would rather prefer the slit lamp marking system to the bubble marking system. So let's understand a little bit. So here, purposely, I'm showing you a lens which is a biotech lens. And I've already marked the axis with the digital axis marker and made a similar marking on the cornea. Inserting the lens is routine once you've done a few of them. Bring the lens onto the right axis. Tuck in the haptics. Check that the lens is on axis. And probably in 4 minutes, the whole procedure is done. I insert these lenses under hydro. I don't use visco because the visco gets trapped under the Fake Iul, and it has 2 effects. One, it could cause a secondary rise of IOP. And number 2, it could cause slippage or rotation of the lens. So hydro insertions are my favorite, and I do hydro insertions as a routine for all my Fake Iuls. Now, coming to whatever we have talked since the morning, I will deal with it in a synopsis. So when we are implanting a Fake Iul, we have 3 categories of procedures. The first 1-step procedure, a 2-step procedure, and a 3-step procedure. My preceding cornea specialists have already talked a lot about it, but just a brief review of how it leads to the Fake Iul. So the 1st-step procedure is that the person has a stable keratoconus and we need to correct it with the Fake Iul. The 2nd-step procedure is we are doing 2 things. We could either do a collagen cross-linking, wait for a few months, let things stabilize, let the cylinder stabilize, and we see many a times the cylinder comes down by a diopter or 2, and then do a Fake Iul, or we are doing an intra-corneal ring segments, and then we can do a Fake Iul almost immediately. Or the 3-step procedure is we are doing 2 things. Intra-corneal ring segment with the collagen cross-linking, wait for 6 to 9 months, and then a Fake Iul, or a TCAT with the cross-linking, and then we do a Fake Iul after 6 to 9 months. So just giving you a few case reviews. In the case 1-stage procedure, this gentleman in the left eye had a vision of 6/18 and had a high cylinder of 3.5, but it was stable for quite some time. And these were the pentacams before. You can see the little eccentricity here and the data showing some early keratoconus. And we did a toric ICL on this date, 15/10/2020. The vision was 6/6. The patient was extremely happy. A simple situation. The drawbacks of a Fake Iul are that it only corrects the spherical and the cylindrical errors. It has no effect on the higher order abrasions. and which are quite a few in keratoconus. So if you have to look at this, you may have to look at a two-stage procedure. These are some references which show that these techniques are very popular. It has been practiced by so many people. So we come to the two-stage procedure. That means before we do the Fake Iul, we do an additional either a collagen cross-linking to stabilize the cornea, wait for 6 months, and then do a Fake Iul, or we can do an intra-corneal ring segments like the Intacs, and probably immediately follow up with the Fake Iul. The advantage of Intacs is that you can almost reduce the myopia by its thickness, pull the eccentricity of the cone more towards the center, more towards the visual axis, and so you get better outcomes with the Fake Iul. Now here's an example of a patient who had right eye diagnosed of keratoconus, and you can see the right eye pentacam shows the typical features, and Belen Ambrosio is highlighting those features here.
You have 1 minute.
1 minute? Okay. So we went on to do the treatment of CXL and then followed it up with the usual Fake Iul. And in stage 3, we used all the 3 procedures. And I'll just show you, see the pentacam values here. And after doing a TCAT and a C3R, look at this, the balance of the front surface is all green and the cone is so well centralized and become regular. And the results were exceptionally good after a toric IOL. And in an intrastromal segment, intracorneal segment, and with the CXL and with the Fake IOL, you can see this picture here. This case was just done about a month back. The results were very good. Thank you so much.
Dr. Sanjay, that was a wonderful talk. I wanted this very important question. We are talking of Fake IOLs in keratoconus. So
Yeah.
the lens sizing can be a challenge in these eyes. So have you had a situation where you needed to do a lens exchange because of the inappropriate sizing? And if rarely if you've had a high vault, you felt because the central flow is there, would you rather wait and watch?
See, the sizing is always an issue because you have an excellent anterior chamber depth, but that depth is confined to the center, not to the periphery. So when we are putting in a ICL or any Fake IOL, we have to consider the peripheral part for our fittings. So we should not be led by that you have an ACD of 4 and 4.5 and you choose a higher size.
Yes.
You could land up with a problem. So your white to white calculations and your dependence on white to white calculations and the ACD by doing gonioscopy, you come see whatever the situation is and then accordingly choose a lens. These days with the centra flow, it is not a problem if you have a shallow vault. Even a vault of 50 to 100 microns is good enough and you don't get a lenticular opacity for years and years and years. So don't be overzealous by choosing a size higher, which can cause peripheral touch and cramming in the angles and cause secondary glaucoma. So this is very important when you determine the sizing, especially in the case of keratoconus.
Thank you. Radhika, you have a question?
Yeah, so I think you took the question that I wanted to ask you. That was a wonderful talk, and I think very nicely from the PG's point of view, he has elucidated that crosslinking has been done to strengthen the cornea, and TGPRK or Intacs have to be done to smoothen the cornea, and then for the refractive correction to go ahead and do the Fake IOL that he has very nicely described. So the same question that Dr. Chitra asked, that in these hyper deep anterior chambers, what is the stability of the lens that you implant? There are so many papers and literature which describe it. But I think you answered the question very nicely that, since the resting point is the periphery, the white to white diameter and the peripheral depth is what really matters. And if you choose that correctly, then the central hyperdeep chamber may not have an influence on the rotational stability of the IOL. That's exactly what I wanted to ask as well.
Yes. I see Dr. Rajesh Sinha is not there yet. I think, Anaga, are you still there? Could you call him up and check? Because he has a very important topic to talk on.
Meanwhile, I'll just like to put across one thing, and that is, Sanjay so beautifully gave this talk. Only sometimes what happens is you do a ICL and the patient still doesn't improve. And I think that is because it is very important. And I think this is what Dr. Ramamurthy has also taught us, that if your spectacle corrected visual acuity is not improving in a case of keratoconus, then it is unlikely that it is going to improve even with the ICL, because they do have a lot of high expectations post ICL. Yes. And they think it is like ICL after myopia. So I think that point needs to be factored in.
And those patients are best left with a good contact lens and a good BCVA. Then we do a fake Iul in these eyes. Yes, it is.
That's a very valid point that Dr. Namrata made. Probably the corneal contour is contributing more to the vision problems than the refractive error itself. So both surgeon and patient will pick this point. Thank you so much, Dr. Namrata.
Yeah. I'll wait for Rajesh to join, but in the interim, we can go on to the next speaker, Dr. Pratik Teotia, who's again a senior consultant cornea, cataract and refractive surgery from Center for Sight, Delhi, and he is going to be telling us about iatrogenic ectasia, early diagnostic indications and management options. On to you, doctor.
Can you see my screen, ma'am?
You have to open up your phone.
I think I've already started screen sharing.
We can see your screen, but your presentation needs to be open.
Okay. Presentation is open. Can you see it, ma'am, now? Let me do it again.
You have opened your presentation, no? Before you came. Yes.
Is it okay?
Yes. Yeah. Fine.
So good evening, everyone. The topic of my today's presentation is iatrogenic ectasia, early diagnostic indicators and management options. So it's iatrogenic corneal ectasia is a rare but most dreaded complication that can occur after uneventful corneal surgery. First, it was described by Professor Theosella, and it can lead to vision impairment and morbidity, causing frustration and dissatisfaction for both patients and refractive surgeons. It's more common after LASIK but can occur after post-SMILE, RK and PRK. And it is postulated to occur as a result of insufficient corneal thickness, exacerbation of pre-existing subclinical or clinical keratoconus by further weakening of the corneal structure, and or the development of genetically predetermined ectasia occurring years after refractive surgery. So the risk factors are preoperative ectatic disease, which may occur despite normal topography, correction of high myopia during treatment in younger age group. In cases of thin cornea, if you leave low residual stromal bed thickness, if there is excessive ablation or thick flap creation during performing LASIK, if patient undergoes multiple enhancements, if there is small optic zone or there is abnormal corneal rigidity, if patient has history of eye rubbing or trauma after surgery. Recently, it has been found that if there are increased level of inflammatory mediators such as interleukin C, TNF alpha, and MMP9 in tears, it can also lead to post-LASIK ectasia, and there could be undetermined factors which could lead to post-LASIK ectasia. This has been discussed that risk score systems have been devised to predict the outcome of post-LASIK ectasia. PTA which is calculated as flap thickness plus ablation depth upon central corneal thickness has to be less than 40% because the anterior stroma is more compact and it has more tensile strength than the posterior stroma. So we would like to preserve the stiff cornea in cases of refractive correction. Despite all these scoring systems, there is no one can guarantee that post-LASIK ectasia will not happen. Despite taking all precautions, we see cases of post-refractive ectasia. So with the advent of advanced tomographers such as Pentacam, we can detect early cases of formophrastic keratoconus, and Berlin ambrosia display and corneal thickness distribution data can eliminate the inherent accuracies of curvature-based measurements. So doing complete corneal tomography and tomography helps in comprehensive evaluation of both the anterior and posterior surfaces, as well as full pachymetry mapping of the cornea is important in establishing the diagnosis of corneal ectatic disease following its course. With the advent of Corvis ST, we can add this in our armamentarium to detect the cases which have low biomechanical strength. Higher order aberration of the anterior and posterior corneal surfaces are altered in keratoconus and have been evaluated as a means of detecting both clinical and subclinical disease. Changes in wavefront analysis, such as increasing of higher order aberrations, particularly vertical coma, other aberrations such as spherical aberration and trefoil aberration may also be present in these patients. OCT, we can get the epithelium map and which show that there is central thinning over the area of the cone and we can get a classic donut-shaped appearance in cases of pachymetry map of epithelium, and this also can help us in detecting early cases of ectasia. It is important to differentiate a decentered ablation from progressive ectasia because in ectasia, immediate results are good. There is no early inferior stiffening, but there is secondary decrease of visual acuity and it shows progression, and laser treatment may worsen the situation, though it is just opposite in cases of decentered ablation. So treatment options for ectasia after laser vision corrections, patient education is most important because these patients are demanding patients. They have chosen refractive surgery for removal of glasses or for reducing dependence on glasses. But in early cases, we may need to depend on glasses or contact lenses. CXL may help in cessation of progression, and for visual rehabilitation, we can go with contact lenses, Intex, PTK combined with PRK and collagen. In advanced cases, we may have to go with DALK or penetrating keratoplasty. For final visual rehabilitation, we can combine various treatment strategies, such as first, we can stabilize the cone with the help of CTR. It will prevent progression of keratoconus. We can flatten the cone and reduce the refractive error with the help of ICRS. And later, we can correct the refractive error and emmetropia with ICLs as shown by Dr. Chaudhary. And in advanced cases, we have to go with DALK and PK. So I'm skipping a few slides that in post-LASIK ectasia, the response to CXL is not as good as in cases of primary keratoconus patient. This is because of biomechanical difference caused by the LASIK flap, possible differences in the riboflavin diffusion rate in post-LASIK corneas, especially at the flap interface, intrinsic pathophysiological differences between keratoconus and ectasia may all contribute to the different response, and response is not as robust as keratoconus patients. ICRS is a modality which is used as for the visual rehabilitation. It acts as a passive spacing agent which flattens the cornea. So there are various rings such as Intex, Ferrara, Kera ring, or BioRing. These rings they are made up of PMA. So with the help of femtosecond laser, we create the channels, and with a special spatula, we open these channels. it is better to create the channels with the help of femtosecond laser because it is more precise compared to the mechanical creation of these channels. So once the channels are open, then we can insert the rings. Either we can insert one ring or two rings depending upon the location of the cone, whether it is central or peripheral. So basically these ICRS work by shortening the arc length of the cornea, and they flatten on and in between the segment tips and stiffen on the segment body. Smaller the diameter, the greater is the correction, and the greater the thickness, the greater is the correction. So this is the Schimflach image showing the presentation of index in the corneal stroma. So whether to do sequential CXL and ICRS or whether to do simultaneous. So CXL, if we do first and then it is followed by CRS, so progression can be arrested by CXL and it improves the corneal rigidity. Corneal shape is normalized by ICRS. Mechanical flattening effect is less than predicted if we implant simple ICRS, and there is delay in visual recovery. Also, the creation of channels by femtosecond laser is difficult, so we need to increase the energy settings of the femtosecond laser to create the channels for ICRS if we plan it post CXL. I prefer simultaneous combination of CXL and ICRS because maximal mechanical flattening effect with intracorneal ring segment and further progression arrested by CXL. Also, they have a additive effect when you do them simultaneously. There is a synergistic effect because of the increased biomechanical rigidity of CXL. It alters pattern and distribution of collagen changes with ICRS, and areas of increased riboflavin concentration between the intercorneal ring segments with increased collagen cross-linkage. So this was a case which patient had this left eye at presentation with mean K 41.6 and the BCVA was 6.9. So at this stage, left eye C3R was done, and despite C3R, patient went for progression during pregnancy. And this was the right eye at presentation with mean K of 40.9 with BCV of 6.9. This patient went for C3R plus Intex, and during pregnancy, this eye was more stable. So from this case, we learned that ICR is a very useful technique modality in cases of post-LASIK ectasia, but we need to prevent this condition. So role of extras has come. The combination of PRK or LASIK or SMILE with accelerated cross-linking has been practiced to prevent ectasia in moderate to high-risk cases. We normally prefer SMILE extra, but nowadays PRK extra is also gaining prominence. Whether it is for everyone, no, the present indications are thin cornea, high myopia if you are treating more than 6 diopter, if there is a family history of keratoconus, if there is topographic asymmetry, and if there is difference in astigmatism between two eyes greater than 0.75 diopter in young patient, and in hyperopes, you can do it to prevent regression. So careful screening is necessary before planning refractive surgery. PRK SMILE might be presumed to have reduced risk due to better corneal biomechanics, new modalities of combining CXL with laser vision correction, and Intex plus CXL may still give a good uncorrected visual acuity after ectasia. Thank you.
Thank you very much, Doctor, for such a detailed talk on iatrogenic ectasia. I have a question to you, Vanti. If you have a patient who has an iatrogenic ectasia in one eye, would you actually ever consider doing a prophylactic cross-linking for the other eye?
We will keep him under observation, ma'am, if the other eye is normal.
No, I want, okay, yeah, you observe. Yeah, I wanted Dr. Vaniti, unmute yourself. The question was to you. Thank you, Dr. Pratik.
Hi, Dr. Chitra. Yes, I think I agree with Dr. Pratik. I would also observe before I jump into doing a collagen cross-linking for such patients.
Yeah. Just another question which might actually make Dr. Sanjay happy. But the thing is, yesterday only I saw one patient of Smile with ectasia with a -2 diopter, unmarried, no allergies, who had got it done some 7 years back. If I look at the topography, I would have still suggested a Smile procedure for her had I seen it now. I mean, but she had gone in for ectasia. So what are your reports all over, like being a major premier institute, they would be analyzing results. Do you feel that anyway ectasia has become very rare because our topographic understanding and the clues which you pick up is so definitive, but do you feel that Smile is nearly on par with the other procedures?
I think when you are screening for refractive surgery, the screening parameters are pretty much similar, whether be it LASIK, whether be it Smile, or whether you're looking at PRK. So it's not perhaps about the quantum of refractive error which needs to be corrected, but the emphasis now is on the corneal biomechanics for a particular cornea, and the way the healing process after the refractive procedure is going to affect the biomechanics in the time to come. So that is the million dollar question as to how is this particular cornea going to react to a particular type of procedure, be it a flap or a non-flap based procedure here. So perhaps the current imaging modalities is still lacking, or there is a small lacunae in which we are not able to clinch on that particular aspect, which is really going to be a biomarker to predict if this cornea is going to go into an ectasia. Till then, we perhaps have whatever we have in our hands, and we are looking at the suspicious topographies. So sometimes perhaps maybe we are missing those subtle markers. And we know today that perhaps we have more subtle markers than what we had 7 years ago. Yes. So that's my take on it.
Dr. Radhika, your question?
Yeah, so basically on the subject of post-LASIK ectasia, so though there are so many parameters which will tell us whether keratoconus is progressing or not, there are very few which will tell us whether the post-LASIK ectasia is progressing or not, because the bad screening becomes completely invalid in a post-LASIK ectasia. We're altering the anterior curvature, we're altering the posterior curvature, the thickness is changed, the relational thickness from center to periphery is changed. So the point that I'm trying to make or ask is that there are very few indicators to know whether the ectasia, once it's unmasked, is stable or is it progressing. Given that context, I would, and also knowing that crosslinking has got very less effect in a post-LASIK ectasia compared to keratoconus, I would err on the side of early crosslinking without waiting for progression. However, years back, Dr. Prema Padmanabhan has published a paper which talks about stability of ectasia and gradation of post-LASIK ectasia. So that if grade 1 is going to grade 2, then we know that it's progressing, including the fallacies of bad and all the systems in finding it out. Dr. Sudhir, if I remember, was a co-author of that paper. So Sudhir, can you shed us some light on how to assess progression of post-LASIK ectasia, and whether you would actually wait to see if the grades progress or whether you would do the cross-linking immediately like I would?
Thanks, Radhika. I think this was a paper where we looked at ways in which how to grade the post-LASIK ectasia using based on the cases which we had seen, almost like 30 cases. And we looked at the elevation parameters, the thinnest point, thinnest pachy, the shift in the thinnest pachy, and also the these are few things which were early markers to identify whether there is post-LASIK ectasia. And again, the cylindrical power, which is increasing. So these were few parameters which we identified and graded them based on the scoring which we developed. And that will tell us whether we are in the grade 1, grade 2, grade 3, or 4. And we can see whether it is, we can follow them if it is in the grade 1. If it is, patient is shifting from grade 1 to 2, then we need to go ahead and go ahead with collagen cross-linking. One more point which I need to add up is whenever we are doing a post-LASIK ectasia collagen cross-linking, the debriding of epithelium, we have to be very careful. You have to know where the hinge of the flap is, and then do the debriding. So that is one more thing which I need to look at. Yeah.
Thanks for yes. Thank you. That was all very wonderful inputs, and we're thankful to Dr. Namrata for chipping in. I think Dr. Rajesh probably forgot about this meeting, and she is going to be telling us about dark in eyes keratoconus and the techniques and challenges. On to you, Doctor.
So, can you hear me, Chitra?
Yes, yes.
Okay, so this might be a little, it's a little change, but I would be talking to you about deep anterior lamellar keratoplasty in cases of keratoconus. And ectasias could be primary or iatrogenic, as has been talked about, and DAL can be done in any of these cases, especially when they become more severe and more advanced cases of keratoconus. And these are the guidelines which have been given when you can do deep anterior lamellar keratoplasty, and this is generally given in advanced cases of keratoconus when the corneal thickness is less than 380 microns. Patients are contact lens intolerant, and of course, when it becomes very advanced, you have to do penetrating keratoplasty. Otherwise, you can even get away with the automated lamellar therapeutic keratoplasty in these cases. So I will just skip this part of ALTK because we are only talking about DALK. The advantages of DALK is that maximal removal of the diseased tissue is possible. The Descemet's membrane is a smooth graft, and virtually there is no interface at all. And like I said, it can not only be done for keratoconus, but also can be done for other endothelial sparing diseases. Now, there are various techniques like the big bubble technique of Anwar, which is the gold standard, the hydrodelamination technique, layer by layer, viscoelastic technique assisted by Melli's, and air assisted technique by the Arkela et al. And contraindications are, although we are still doing it in healed eye drops, but these are contraindications whenever there is any endothelial involvement. Now, we do prefer to do under general anesthesia, although peribulbar anesthesia can be used for these cases, and topical anesthesia should never be used. And donor tissue with poor endothelial quality can be used. Avoid tissue with a heavy arcus, and a backup good quality tissue should always be available. Now, this is just to show the technique by Mallis, which is, I think, the safest technique. Air bubble is put inside the anterior chamber. A 400 microns groove is made. Lamellar dissection is then done from limbus to limbus, following which the viscoelastic is injected. So because you're doing a lamellar dissection, you are not near the Descemet's membrane. I mean, you're not exactly above the Descemet's membrane, but near the Descemet's membrane. So then viscoelastic is injected, and then sutures are placed onto the incision which had been made earlier. And then following which trephination is then done, and the anterior part of 400 microns is removed. And so you do reach up to the near Descemet's membrane level, and after excising this, a full thickness donor cornea is taken, which is bereaved of the endothelium, and then is sutured tightly with 10-0 monofilament nylon sutures. When the host graft disparity is generally kept less, about 0.25. Some people even like to keep the same size graft. Now, with the advent of Dua's layer, the way we look at DALK has completely changed. So Dua's layer is nothing but it is the condensation of the stromal keratocytes, as is shown here. And if you have a bubble that is instilled above Dua's layer, it is type 1 big bubble. And this will have a rough surface because there's Dua's layer which is staring at you. And if it goes beyond this Dua's layer, then you have a type 2 big bubble, and it's going to be absolutely smooth and glistening because Dua's layer is not there at all. So it is a smooth surface. Now, there are two types of big bubbles. This is the big bubble type 1, in which the partial thickness trephination is done, and this is followed by the air bubble, which is instilled at a depth of about 70%. In fact, it goes into the pre-Descemet's membrane compartment, and this can be appreciated on the intra-OCT microscope. The Descemet's membrane has fallen back. This is, of course, an inverted image. And as you give a nick in the overlying stromal layers, the air bubble egresses out in a live show, and so does the Descemet's membrane move on the intra-OCT microscope, which actually see in the surgeon's eyepiece, and you know that you are in the correct plane. And then viscoelastic is then instilled. So again, this would move behind with the viscoelastic just like a kangaroo's pouch, and this is just playing on the Descemet's membrane, and this is the bare Descemet's membrane which is looking at you, and this is then sutured with 10-0 monofilament nylon sutures. So the type 1 big bubble went from the center to the periphery. Type 2 big bubble goes from the periphery towards the center, which you can see here. It has come right up to here. And this is again 70% trephination which has been done. This is followed by the AC paracentesis. And just watch this bubble. It will expand a little bit as you do AC paracentesis. And when you do AC paracentesis, the Descemet's membrane kind of falls back. And so when you're Giving a nick in the overlying stromal layers, again, this will come out, and this comes out very quickly now. So watch for it. As soon as you do this, the Descemet membrane is again moving upwards. Then again, this is viscoelastic is instilled, and again, this will fall back, and then dissection is done over this. Just to show cases of DALC in cases of keratoconus, the results are pretty good with a perforation rate of 4 to about 13%, and successful big bubble is obtained in almost more than 80% of the cases. Now, in cases of healed hair drops, also I said you can do DALC, and you need not do it with the IOCT. But what happens is that if the areas of the healed hair drops is a little paracentral, as can be seen here, you can do a layer by layer dissection. And this is done after doing trephination, giving a nick. And as you do dissection layer by layer, just as you come to the area of the healed hair drops, go a little anterior. So you go a little anterior, and the scarred area moves little paracentral, which can be seen here. But in the post-operative period, the remodeling would occur, and this is just 52 microns. It looks pretty clear because the scarred area has been removed, and very little what was left has moved to the paracentral area. When you have keratoconus with pellucid marginal degeneration, then you can do a tuck-in lamella keratoplasty. And here, basically, a flange is made all around. I think I'm not going to talk about it because I'm sure Dr. Radhika is going to show this. So we then come to penetrating keratoplasty whenever there is full thickness scar for which you have no choice left but to do a full thickness penetrating keratoplasty in these cases. A bit about a new type of keratoplasty which we are doing with the bioengineered corneas, and that is intrastromal keratoplasty. And this is not deep anterior lamellar keratoplasty, but it is done in cases of advanced keratoconus. So a pocket is made with the help of femtosecond laser. This pocket is then opened up, and we have now bioengineered or biosynthetic cornea. So this looks pretty much like the contact lens. This is folded. This is obtained from recombinant technology, and this is then unfolded inside. So it reinforces the corneal thickness, and then you don't need sutures in this. You can just put a bandage contact lens, and this is then in the post-operative period, these patients do quite well. So thank you very much for your kind attention, and thank you, Chitra.
Yeah, that was a wonderful talk, and we really needed this talk because this session is so incomplete without it, and thanks for being so supportive at this point. But just a question, do you think that manual dissection cases as against big bubble would have definitely poorer visual outcomes in these eyes?
So the manual big bubble, whenever you come up to the Descemet's membrane, then of course the quality of vision is much better as compared to the pre-descemetic DALC. But having said this, in terms of the visual acuity qualitatively, I think there is not too much of a difference. For instance, there may be 6/6 both ways, but perhaps the contrast would be better with descemetic DALC than with the pre-descemetic DALC.
Dr. Radhika?
Yeah, so that was a wonderful talk, Dr. Namrita. So like you yourself mentioned, probably there are two aims to doing a DALC. One is to remove as much disease tissue as possible. And like you beautifully showed in your surgery, the interface is very pristine. In fact, there's no interface at all when you leave back just the Descemet's membrane. So the quality of vision is very good. But the question that I want to ask you is that now is the day and age of tuck-in stromal lenticules for keratoconus. As also you showed the bioengineered synthetic tissue, which can do the same job. So here again, in fact, the issue of interface becomes double. There are two interfaces now, and we are not even removing the diseased tissue of the keratoconus. So the question that I'm asking is that then would it be also equally prudent to revert back to just lamella keratoplasties, which are not full thickness, so that the learning surgeon can learn it easier and we get the desired result also, even though we are not at Descemet level, even though we are not removing the entire diseased tissue?
You're quite right. I think I completely agree with you, because we move back, not move back, but everybody is trying to move back to intrastromal keratoplasty, which can be done with a donor cornea or can be done with a biosynthetic, with the synthetic material that I showed you. The only problem is that when you do it with a donor cornea, just like a DSA graft thins over a period of time, likewise, the donor corneal lenticule would also thin over a period of time. But that will not happen with the synthetic cornea. But yes, the problem of double interfaces continues to be there. And the advantage of a desmetic DALC is that there is a interface, but that's not visible at all.
Thank you.
Thank you. Thank you, Dr. Namita. So we shall go on to our next speaker, Dr. Nikhil Gokhale, from Senior Consultant at Gokhale Eye Hospital. Again, an extremely dynamic, versatile surgeon. And I'm sure he'll tell us a lot about pellucid marginal degeneration, current available management options. On to you, Doctor.
Thank you, Dr. Chitra. So I thank the ARC and the AIOS for giving me the opportunity to read up about pellucid after quite a lot of period of time. So basically, whenever we come across a case, I think as postgraduates, we need to understand that are you dealing with a case of a PMD or a keratoconus or keratoglobus? They can all look very similar. So sometimes the ectasias are confusing. So I think we need to look at clinical picture, the clinical presentation and topography, and then try to make a difference between what we are trying to treat. This was one of the articles that I came across, which does show the various options we have in managing a pellucid degeneration. I would like to stress that about 88% of the patients in literature have been shown that they can be managed non-surgically. So all this big chart, you see a small, single option of non-surgical treatment, but that is what can be probably adequate in majority of the patients. And as you can see, a number of surgical options are there. However, we must understand that many of these options will still have unpredictable outcomes. They require a high surgical skill and might still leave us with irregular astigmatism. Having said that, we have cross-linking today, which can be a good option to stabilize the pellucid, and then try contact lenses, which can give very good quality of vision. And with the pros of the scleral lenses, even with advanced ectasia, you can have a very good vision that you can deliver to these patients. Having said that, again, a very large number of eyes that have been reported by this recent article from LV Prasad, which again stresses the fact that they could treat about 87.97% of the patients non-surgically in their practice, of which about 60% were managed just with glasses alone, and the rest, about 28%, with contact lenses. And amongst the surgical options, as you can see, the most commonly procedures that were done was a cataract surgery and a cross-linking surgery, followed by a penetrating keratoplasty, and a very small percentages of the other lamellar procedures have been done. So basically, what I thought I would go through is the various options we have at this point of time, and just to make us more aware of the various surgical options, although the indications are limited. Glasses are often well tolerated, and they do improve the Snellen's vision, at least in these patients, unlike in keratoconus. So they could have a 6 or 7 cylinder and still see 6/6 in a pellucid degeneration, unlike in a keratoconus where the vision does not improve with glasses. Contact lenses, depending on the grade of pellucid, could range anywhere from a soft lens to a prose lens. And we have the RGP lenses which come in between. With regard to surgical procedures, in the past, I think a penetrating keratoplasty was done quite often. However, we don't do it very often today because we understand that we have to do extremely large grafts if we have to take the area of the ectasia and excise it. So which brings us very close to the limbus, and therefore we end up with suture-related problems and a very high risk of getting rejection and rejection-related graft failures. To probably not remove the central cornea, which may not be affected by the pellucid, one option could be to do a crescentic wedge resection, whereby you just remove the abnormal tissue, which is thin and ectatic, and this reduces the vertical length of the cornea and improves the shape and the vision. However said, it is a challenging job to suture some of these corneas, especially if they're extremely advanced, and they may still have refractive instability and astigmatic drifts. As we just heard, DALC can also be a good procedure because we don't have the issue of endothelial rejection in these patients. However, they are again surgically complex procedures, especially when we have patients with extreme ectasias and extreme thinning in the periphery. It's a nightmare to dissect these tissues except in maybe very surgeons who are really having good experience. Lamella wedge resection is again an alternative to a full thickness wedge resection. However, as we understand, if we try to remove a large wedge of tissue in a patient, we will have extremely deformation and folds in the corneal tissue. And to circumvent this, some people have tried to develop what is called wedge resection with a dissection of the cornea. So you do a deep lamellar dissection of the cornea, and when you do the wedge resection, there is a lamellar sliding of the cornea, which probably gives rise to less distortion and less folds in the cornea when you suture the wedge. So these are some of the schematic pictures where you can see dial dissectors used to first dissect the cornea up to the area of the thin area, and then you excise a crescent and then suture it tightly, trying to overcorrect on the table so that it eventually comes to a more better shape. You can also excise a crescentic tissue and then replace it with a lamellar graft of tissue. However, to make this procedure more sort of effective, what we need to do is to do tight suturing and undersize the donor tissue so that there is basically a shortening of the vertical height of the cornea, and then you can probably get a better shape orientation to the tissue. And you can also combine it with a penetrating keratoplasty, either in the same sitting or do it at a second sitting. And as we just saw, Namrata, tuck-in lamellar keratoplasty, which has been described by Dr. Vajpayee, is an excellent technique in these procedures, where you create a peripheral sort of a groove and pocket, and then you dissect the stromal tissue with a little bit of a peripheral flange, which is then used to strengthen the peripheral cornea, and this can give very good results. This is just one patient I had who had extreme ectasia, which was there extending to the limbus with a central hydrop scar. So I did a tuck-in lamellar keratoplasty on the first stage, but because of the central scar, his vision was not improving well, and I did a penetrating graft subsequently. And about he's more than 10 years follow-up now, he's maintaining good vision. So you can get good visual acuity in some of these patients if you judiciously choose your options. Cross-linking can initially, we were skeptical. It was an off-label indication to try and use it for pellucid. However, there are several reports which do show good results of cross-linking in pellucid marginal degeneration. And at this point of time, I think doing a cross-linking followed by a good contact lens fit could be the most optimal treatment for a patient with pellucid. So this is one patient where you can see significant flattening in the area of the ectasia following a PMD. This was a patient, this is the first eye, and this is the other, this is the other eye of the patient where the cross-linking was done in 2010. In 2014, if you look at the difference map, you can see there is significant flattening of the cornea. And 8 years later, again, there is still further flattening. So one of the things that we see in some of these cross-linking procedures is that they continue to flatten progressively over a long period of time. The map which I have not put here is after 12 years of cross-linking, where you do see some amount of steepening coming back again. Although he's still better than the pre-cross-linking picture, the effect of the cross-linking can sometimes start regressing, and you might have patients who might progress after many years of cross-linking and may require a repeat procedure. So in conclusion, I would like to say that if you come across a pellucid degeneration, if it's mild, probably glasses work good enough. If it's moderate, you can try contact lenses, the regular type of contact lenses. And with severe disease, you may try semi-scleral or scleral lenses. And if really indicated, try to do surgery. However, you need to understand that you need to have good experience trying to do surgery in these patients. And if you have a progressive PMD, you can definitely do a cross-linking followed by contact lenses. I spend a lot of time counseling many of my cornea patients who feel that surgery is much cheaper than doing a contact lens fitting. It's a one-time procedure, and they often consider it as a shortcut treatment to an ectasia. And I think we need to spend significant amount of time trying to tell them that these procedures can be less predictable and less safe in the long term. And in their interest, it's better that we try to do procedures which are more predictable. Thank you.
That was a wonderful talk, Dr. Nikhil. It was really worthwhile your reading up, as you said. I don't think you need to read up much, knowing you over these years. But I wanted to ask you one question. Like, if you see a patient of PMD, would you often observe these patients, then crosslink progression being lesser in these eyes? And when you crosslink, what are your tips? Would you decenter it? Would you create a larger epithelial defect? What would you do?
Yeah, so basically we need to understand that PMD often is diagnosed at a much later age compared to a keratoconus. So I have had patients who have had more than 10 years of follow-up and have not progressed at all.
Yes.
So of course, some of these patients had advanced PMD even at presentation. However, you do see patients who are detected at a much younger age today, maybe because they go for LASIK or they go for some sort of procedures. So if you detect a PMD at a much earlier stage, probably you're in a position to document progression. So I would normally follow these patients up and look for progression, because PMD in general will progress not like a keratoconus and it won't jump fast. However, if you pick up early cases, there are these patients who might progress slowly over decades actually. So that is why even after the cross-linking, as I showed you, to say that it is stable, we need to really monitor these patients for a very, very long period of time to say whether it's a cross-linking or it's just a natural history of disease. Regarding the cross-linking, of course, I try to do a decentered sort of cross-linking where the defect tries to go more closer inferiorly or wherever the area of ectasia is there. And at least I have not observed any endothelial burn or corneal edema in that area. Although the cornea looks thin, maybe the angulation of the cornea is such that the beam probably does not hit the endothelium, and we don't get gross endothelial injury in these patients.
Thanks a lot. That was a very succinct answer. Radhika?
Yeah, I completely agree with Dr. Nikhil that the term contact lens intolerance is sort of overrated. Quite often, if we control any allergy, PMD is not associated with allergy, but generally allergy of the patient is under control. We dispense the correct power, fitting, and material, and we take the time to counsel the patient the risk benefits of these, non-surgical versus surgical procedure. We find that the contact lens acceptance becomes very high in these patients. Dr. Nikhil, in addition to the points that you mentioned in the cross-linking, we've often seen that PMD equals inferior. Quite often in the 8mm maps, which the Petacam throws at us, we may miss a PMD. So if there is a suspicion, would you recommend viewing a larger picture? Because I've personally seen that it gets completely missed in the early stages when you see only a short picture, whereas the 12mm map that actually, brings it to light. And likewise, along with the other tips that you said about cross-linking, would you also, you said endothelial damage is not a problem, but is limbal damage a problem? Would you advocate limbal protection if you're using a decentered or a larger UV beam for the treatment?
Yeah, so basically one thing was that whenever you see any high against the rule astigmatism, which looks more than usual, the assistant will never look at the limbus or the perilimbal area. But I think as with experience, we realize and we try to look at that area for a PMD, which is often missed by, by a routine clinician or a ophthalmologist. And as you said, you can take bigger maps and you can also do an OCT with trying to look at the thinnest area. Otherwise, sometimes very difficult to measure what is the thinnest pachymetry in that area. So sometimes I use a ASOCT to ask the patient to look little up and then try to take a scan which is perpendicular, and then you can probably also measure thickness more reliably. And of course, limbus, we have to take precaution that we do not, sort of cross the limbus, definitely. Although we are going pretty close to the limbus, we definitely don't debride, because we also understand that the limbal stem cells may get damaged in that area. So we need to take precaution. I totally agree. I think I missed it. Thank you.
Thank you very much, Dr. Nikhil. So paucity of time, we have to go on to our next speaker. Dr. Radhika Tandon, who needs no introduction, who's a professor of ophthalmology from Rajendra Prasad Center of Ophthalmic Sciences, New Delhi. And she's one woman who's completely dynamic with the kind of publications and textbooks and book chapters. And she's also a chairperson in Low Vision Services and immediate past president of the Eye Bank Association of India. And we are truly enlightened to have her as a speaker amongst all the other very impressive set of speakers we have. And she's going to tell us something about not a very common disease, keratoglobus, and how it can be a challenge in visual rehabilitation and the surgical management. On to you, Dr. Radhika.
Thank you, Dr. Chitra. Thank you for the opportunity to participate. And I must say this session has been very well planned and all the speakers have covered this topic extremely extensively. And of course, the question and answers have also been very illuminating. Coming to keratoglobus, which is another important ectatic corneal disorder. It can also be a great challenge, and it's the management of such cases which can be very difficult for the physician and the corneal surgeon. So basically, just to give you an idea about the definition of keratoglobus, when you have keratoglobus, it is an overall ectasia with an overall thinning and a globular protrusion of the cornea. Like the other ectatic disorders, it is a bilateral and non-inflammatory ectatic corneal disorder. Generally, it is non-progressive or minimally progressive. So if you have a history of a patient where the numbers has increased a lot over ages, then you may be prudent to say that is it really keratoglobus, or is it a very advanced pellucid marginal or a combination of pellucid marginal and keratoconus? And there's a typical globular protrusion, but as I mentioned, often even very, very late stages of PMD or PMD associated with keratoconus, they can also have very sort of globular ectasia, and it can be difficult to differentiate. Having said that, it doesn't matter, because even that, so the management, again, the principles will be remaining the same, and it's not that you're going to do anything markedly different. But as this is a PG teaching session, I would like to specify that when you have to differentiate, to understand the difference in anatomy and the way the patient actually presents, it is a generalized thinning, which is a clear giveaway that it is more like keratoglobus than the other two. Associated clinical features are known in keratoglobus. You can have scleral thinning. They can be also very, compared to the others, more prone to corneal rupture. And they can have acute hydrops, but relatively less commonly compared to keratoconus and PMD, but it can happen. The reason I'm specifying scleral thinning is because in case any time this patient is going for cataract surgery, then that needs to be taken into account, and the next speaker is going to cover that. And prone to corneal rupture is extremely important, because when you detect a child or a person with keratoglobus, it's very important to make them aware, the family aware, and they have to make very active effort to protect the eye from trauma and avoid any contact spots, wear protective goggles, etc. So as I explained before, the main differential diagnosis is keratoconus and pellucid, and basically sometimes in very advanced stages, it can be difficult. And of course, if you have a newborn coming with this kind of an appearance, then you have to think of the possibility of congenital glaucoma and congenital megalocornea. In both these conditions, the corneal diameter is a little larger. In the case of keratoglobus, it's usually a normal or slightly larger corneal diameter. And of course, in congenital glaucoma, there will be increased intraocular pressure and the other associated features of lacrimation, Harb striae, photophobia, and so on. Now, just to give a little bit about tomography, as we were discussing earlier, so just giving an example of how there is this patient who was actually diagnosed as keratoglobus. It was a very marked ectatic globular protrusion in one eye. But if you see the tomography, the other eye is like this kind of a sleeping bow tie or a crab claw appearance. Is very characteristic of pellucid marginal degeneration. And to have this in one eye and the other eye having this kind of an appearance is more likely that it is a PMD with KC, and you could give the possibility of keratoglobus. And then you look more carefully, you take the larger diameter pachymetric maps, and you see if there is a diffuse thinning, like as you can see in this different case, how there is a very diffuse thinning all over, which is more typical of keratoglobus than the other two. Now, the goals of treatment, again, I would like to emphasize that eye protection is extremely important because they can really come back with terrible corneal ruptures. And visual rehabilitation, the usual, you start with glasses, contact lenses, and then you would have to go for surgery if required. And surgery would also include, if you do get an acute eye drops and a DMD, be aware that in such patients, sometimes they can have very large descimate tears. Like there can be a complete ripping of the descimates as opposed to the relatively smaller tears that you may get with keratoconus. Now, coming to the surgery, once the same indications for surgery as all my previous speakers. And here is that paper Dr. Vajpayee very nicely invented or demonstrated or taught us this technique so many years ago, which is still relevant even today. A tuck-in Lamella keratoplasty. Basically, as I explained in that picture, that there is a limbus to limbus thinning. So the entire cornea has to be replaced and it has to be strengthened. So if you do a limbus to limbus penetrating keratoplasty, as used to be the norm, there's a higher risk of post-PK glaucoma, higher risk of rejection, and so on. And since these patients' endothelium is actually healthy, so you could reinforce the cornea and also regularize at ectasia by doing a tuck-in Lamella keratoplasty. And the peripheral cornea, a small rim can be thinned and then it is put in place and then sutured in to sort of to flatten the cornea. But do be aware that by this, we do get a few descemet folds, and they can be sort of these concentric descemet folds, but they usually iron out with time. So when talking about the clarity of vision after these procedures, it's not only the remnant descemet membrane, but it is also that little distortion which is produced by flattening that cornea. And here, Dr. Grusin has suggested that if there's a very ectatic cornea, you just do a through and through perforation, a single perforation with an MVR blade, and then suture it to reduce the problem of those folds. So coming to this technique as an actual surgery here, this is the original video of Dr. Vajpayee, where this is the surgical demonstration of this is the patient of keratoglobus. Notice how there is a diffuse thinning all over. With a large diameter trephine, you make a mark, and then you do a lamellar dissection using a crescent blade, making a pocket all around. This particular case, it's a little inside the limbus. The benefit of this tuck-in is also that to avoid damaging the limbal stem cells, you're able to spare them. And then you tuck in the donor. And again, as the donor, we're not replacing the endothelium. So you can use a donor with a lower endothelial count. A younger patient who would like to take a donor where there is no arcus, because as you can see, it's a very large diameter graft. If you're an older patient, maybe even that arcus doesn't matter too much, and then you can decompress. This is another thing that you can do to help to press down the ectatic cornea and then suture in. And instead of doing it at the limbus, Dr. Grusin has suggested you can do it right through it. And this is the more recent surgery, and I had a slight perforation. So therefore, I put in air and I was able to seal the perforation with fibrin glue and then continue with the lamellar dissection. And if the cornea is very thin, don't hesitate not to go very deep. You can leave a thin layer of stroma, because it doesn't matter if the patient gets 6/12 or 6/9 vision, because they have so many other problems. It's also the astigmatism and so on, which are a problem. This is another video of a recent case, which I'll show you. Now, this particular patient, again, was actually more like a PMD combined with keratoconus rather than a true keratoglobus. But as I said, the surgical principles remain the same. So make a large diameter hole strephination, and then you with the crescent blade, in fact, this was so thin, the cornea, that I really literally used the donor the trephine simply to make a mark, and then it was along with the crescent blade that I had to deepen the groove. If one has a diamond blade with a micrometer, that can also be used to help to deepen the groove, and then step by step you go deeper and then make the pocket. And then this is the donor tissue where as you can see, it had to be very large, literally going up to the limbus. And the periphery can be thinned down to make it easier for you to fit it in. and then it is sutured in place. And this particular patient, you can see there is a marked AIOS, but the recipient was also 55-year-old. And we were not that concerned about the prosthesis. The patient did well post-operatively. So the surgical pearls, if you have a perforation, unless it's like a very big rip or a very big tear, don't worry, put in an air bubble. You can often, that itself can tamponade it, give it a few seconds, and then you can use fibrin glue if it's available. Otherwise, you can, just start from another area, and by the time you come to this side, usually that air has given you enough tamponade for you to be able to excise, or you can, with the scissors, leave a little stump of cornea there and then leave the air bubble to tamponade it and put the donor cornea, rather than immediately switching to a penetrating keratoplasty. But yes, these cases are very challenging, and it is prudent to have a healthy optical grade donor tissue also available as a backup. I'd like to thank Dr. Amit Das, who helped edit that video for me. And in fact, the video was not running, and he quickly changed it to another format and sent it to me now. So thank you so much, everyone.
That was a wonderful talk, Dr. Radhika. It was like actually like reading a storybook. It was that interesting for me to watch today. But till when would you observe these cases? Would it be like it's a one-eyed patient where the other eye has been lost to a very trivial trauma? Those kind of patients you would select to do a surgery? Or
it's a very difficult question, because the surgery is not simple. The surgery is not a wonderful solution to everything. You could go by the extent of thinning, because not all of them have such a thin cornea. And usually keratoglobus is non-progressive, but I find in our country, all the pathologies don't follow the book, and you often may find very severe thinning as well. So I would say that if the cornea is 300 microns or so, patient is sensible, you can take care of eye protection, I would say go for in fact glasses. Even contact lenses can give a very good vision, but it's not easy to fit the scleral lenses. It's not easy to wear them, not easy to remove them. So I would say that you have to be very conservative, and on a case-by-case basis, you will have to take that decision.
Dr. Radhika, would you take a question before we go to our last speaker? I'm very sorry, Dr.
Very quickly. Thanks for that lovely presentation, Dr. Radhika. Keratoglobus, we know, is a very, very rare entity. Even after so many years of practice, we see only a few. But in that also, we see a subdivision where on one hand you have only keratoglobus, on the other hand you have maybe blue sclera and body problems in terms of collagen disorders, which has led to the disease. So my first question to you is, what will be your threshold for referring these patients for a physical evaluation? Would blue sclera be an indicator of any underlying systemic biochemical abnormality? And the second is surgical, the tuck-in that you beautifully showed. When you're putting the donor graft, do you feel there's a need to de-epithelize the periphery? Or because we are tucking it in very peripherally, if some epithelial cells get into that pocket, it shouldn't matter at all?
Yeah, both questions are very important. See, it's a clinical assessment. If you see associated blue sclera, then definitely one should go, because there could be associated other collagen vascular disease, osteogenesis imperfecta, and particularly if you see a child, a very young child, a newborn, and you find this blue sclera, that's the time that one should, because then associated investigations will give them the family the extra precaution that they have to take about avoiding falls, etc. Regarding the epithelium, no, I do not make any conscious effort to remove that epithelium. It's will shed off, and the orientation is such, it's unlikely to go down and produce any epithelial growth or anything like that. Yes.
I can just give a comment on that.
Yes,
I think, about the epithelium part, I think even our reviewer asked us when we sent this paper that you might have epithelial ingrowth. So what we started doing was, we started doing it from the other side. I mean, we started doing it from the anterior side. We started removing the epithelial part rather than the endothelial ledge that was initially described for removing it. The epithelium part we started removing to create that ledge. So it became like a hat, there would be full thickness, and then there'll be a small step there and then ledge, rather than from the back side of the cornea.
So if I get you right, it's a two-in-one thing. You're deepithalizing it and thinning it out at the same time by doing it from the anterior side.
Yeah.
Yeah, I understand. That's right.
Thank you very much, Dr. Radhika. Do stay on to this last speaker. And we have a very patient young doctor, Dr. Rohit Bhang, who was just erroneously made the last speaker from Sri Krishna Netralaya in Aurangabad, Maharashtra. And he's also going to tell us something very relevant to all of us, cataract and ectasia. What are the pre-operative and the intraoperative challenges? So on to you, doctor.
It's almost a session which has been running since last 2 hours, and everyone is stuck up and everyone is so engrossed with it. So coming to the last part, cataract and ectasia, what could be the pre-operative and intraoperative challenges? At the outset, I would like to thank Dr. Chitra and AIOS. I am thankful to Dr. Inar Madam, whom I had worked with, or she was my teacher at Shankar Netralaya. So the main problem, we had been discussing keratoconus all throughout, and a lot of things has been clarified all throughout. So the main problem is IOL power calculation and the refractive outcome in ectatic corneas. So the three pillars that we need to look, what I would emphasize is the age of the patient, the stage of a keratoconus or ectasia in general, and whether the keratoconus is stable or is still progressing or unstable keratoconus. So the age as such, it could be a young patient, middle-aged patient, or an old patient. The stage of keratoconus, it could be mild, moderate, or a severe. And what we need to look at, stable or unstable cornea, or stable or unstable ectasia as such. So a lot of things depend at what stage, what age the patient presents to us. Like in young patients till 35 years of age, it's a mild treated keratoconus and stable K readings. As we had seen all through.
Maybe you should switch off your video because, you know, the network is weak at your end. And you have to unmute yourself. You got muted. Unmute yourself and maybe switch off your video. Maybe we can hear you more regularly.
Okay, now you're able to listen me?
Yeah, yes, we can.
Okay.
Yeah.
Sorry.
It's not moving?
Yeah, okay. So in a young patient, you need to get your topography done. First and foremost, confirm whether the keratoconus is stable. And then you do a optical biometric comes into your picture. The more probably what you are going to rely on is a Hegel formula, and you can combine it with Shamas or Holaday too. We need to make sure that all the readings are in a similar range where you can have a rough assessment that your readings are reliable. Whenever you have a progressive thinning, more than 5% loss of pachymetry, it indicates that you are still dealing with a progressive keratoconus or increase in a.
Can you switch off your video and talk? There is a good, can you switch off your video? Switch off the video and then maybe you'll be able to talk continuously. You have no mute and stop video. Mr. Shari, could you help him?
Stop video, okay.
Not your the presentation. If you are not seen, and then sometimes it becomes better.
Rohit, you have the mic and the video option in Zoom, right? Through which we see your face and hear your voice. Just keep up the mic alone, unmute the mic, but you stop the video so that we don't see your face. The reason being when the connectivity is less, it helps.
I got you. Okay, that's better.
Yeah.
Okay.
Now it's better. Yeah.
Yes. So when you are seeing at unstable cornea, obviously, as has been discussed previously, you need to stabilize the cornea. To stabilize the cornea is obviously by a CXL or corneal collagen. K's are very steep. You need to combine you need to do a CXL plus, which will be a CXL and combined with the ICRS or a CXL with the TCAT, so as to make the surface more stable or better, or reduce the astigmatism as such. After any sort of corneal intervention, wait for minimum 6 months before you actually plan for a cataract surgery. middle-aged patient with a stable or a moderate, stabilize that your keratoconus is stable in a relatively middle-aged patient more than 40 years. We don't expect keratoconus to progress further. And sorry.
Can you change your network to your phone? Sometimes, then.
Yes. You're able to listen me now?
Yeah, yes, no, it's coming in breaks. Yes, go ahead.
Okay. So the toric IOL would be an option. However, in the cases of irregular cornea or irregular astigmatism, even toric IOLs won't give you a satisfactory results as such. So wherever you are looking at a very steep corneas in a range of 55 or something, you need to treat the cornea as such. How we are going to reduce the K value is by ICRS or intracorneal ring segments. And then you wait for 3 months minimum, repeat the pentacam or optical biometry, and then you can plan for a cataract surgery or a phaco with a toric IOL. However, in a you might have to combine it with a DALC and a phaco with an intraocular lens implant. And at times in a patient who has already have a scarring, either you can think of a manual DALC, or you might have at times to combine go ahead with a penetrating keratoplasty with a cataract and a IOL implantation. So this is a small video clipping where we had been doing a DALC combined with a phacoemulsification and IOL implantation. As you can see, there is an apical scarring, and like ICRS or toric ICLs won't be won't be a suitable option. You need to remove the obstacle or the so this was a patient who had a central scarring, which gave me good enough visualization for my cataract surgery or phacoemulsification. Close my incision or phaco incision with a single suture and then proceed with a manual DALC. So it's a peel and groove technique that we do in a manual DALC. You put a small air bubble and try to keep your dissection and start from the periphery and then move on to the center. So once that is done, you just run through. And your routine suturing as such. Patient who has already undergone ectatic corneal surgery like cross-linking or ICRS, or you are looking at RK patients, or a patient who already has an ICL and a cataract as such, or a post-PKP patient. So what you need to look for in a post-cross-linking, you need to wait minimum for 6 months before we plan for a cataract, and have a faint corneal haze in the cases of a post C3R. So your visualization might be hampered. In the cases with a post RK or a LASIK, biometry issues can be there. The surgical difficulties as the cornea is not steep enough. Also, you need to keep a watch that how many RK incisions had been there. At times, you would find RK incisions might open up, and you might have to suture those incisions if there are more than 8 incisions that had been given. And the rehabilitation time might be a little longer than your routine phacoemulsification. That has to be very well explained. So similar thing with the post PKP, where you would like to wait for more than a year with a full explanation of chances of a rejection and soft shell technique so as to protect the endothelium and keep a small air bubble for endothelial coating. So coming to take home message, let's say that the central K readings from minimum 2 different machines so as to ensure that you are getting the reliable or quite a reliable readings, and a minimum 6 months stability period before we take up the patient for a cataract surgery. In the cases of keratoconus, the young patients are unlikely to require cataract surgery. However, the middle and old age patients usually have a stable keratoconus, either post C3R or with the aging. The cone if the keratometry. In the cases of PM, sure that it's not progressing, you can plan for a customized toric IOL which would give a very good amount of correction, but you need to very well explain that there could be a still residual astigmatism and the need for a correction. And a very important point will be adequate preoperative chair time should be given to those patients so as to solve the post-op grudges. Thank you.
Thank you, Dr. Rohit. That was a lot of details there, though the signal was not good. I would want to ask this question from both Dr. Praveen and all the expert panel. Dr. Sudhir, in a age-stabilized keratoconus and the patient is very keen on getting good results in cataract surgery, would you consider doing a topo-guided PRK in those mild keratoconus patients which are coming to us for cataract surgery nowadays? Would you want to do the topo-guided regularization and then do a cataract surgery? And more so if it is a toric IUL which this patient wants, your thoughts? Dr. Praveen?
Yeah, if I can go first, I think if a patient is stable keratoconus and there is no need to do cross-linking, then for correction, we would not do a topo-guided treatment and add on cross-linking. I think cross-linking and topo-guided treatments are only for those who are progressive. For those who are stable, I think if they have irregular astigmatism, then contact lenses, if they have regular, like Rohit very beautifully showed, a significant amount of correction will be achieved with either a cataract, with a toric IOL, or like Dr. Chaudhary showed earlier, also Fake Iul.
Not cross-linking, just a topo-guided regularization.
No, probably not.
Yes.
No for me also.
Yeah. No, I just wanted it as a discussion question. I missed out on some of Dr. Rohit's slides. Would you prefer to do a scleral incision in these cases or a corneal incision when you do a cataract surgery?
Hello.
Yes, Dr. Sudhir, wanted to ask you.
Yeah, I think it doesn't matter whether it's a scleral or corneal incision, as long as now with your minimal 2.2, I don't need to worry about the incisions. But in case of RK, absolutely yes. I think we only need to do a scleral incision, unless until if it is a very like only 4 or 6 incisions where you have in between the space between the 2 incisions is good enough, then you can go for a clear corneal. Otherwise, the clear corneal is good enough. More clear corneal, it should be a limbal incisions.
Yes. Thank you, Doctor. Dr. Radhika?
Yeah, thanks, Dr. Rohit. Rohit is our own alumnus from Shankaracharya, who's made a wonderful mark for himself right now. So nowadays, we collagen cross-linking treatment has become the standard of care over long years to arrest keratoconus, and all these patients have been stopped from progressing, and they will grow older and they'll get cataract definitely. Many of them are coming for cataract surgery even now as we speak. So my question probably to Dr. Praveen is that we know that with the earlier example of refractive surgery, we did have issues with the DBR because the anterior cornea got changed, the posterior cornea got changed, and the relationship between the two got changed. And now with cross-linking, the same is happening. We're changing the curvatures of the cornea. In addition, probably we're even changing the refractive index of the cornea because of inducing the demarcation and everything. So are the current DBR techniques, requiring any tweaking when the patient has undergone a cross-linking treatment, the more of the type that we are going to see in the future, or because it's already an irregular cornea, shouldn't that minor difference matter at all?
I think I'll probably just make a point before answering your question, Dr. Radhika. One is the fact that if somebody has a cataract with the keratoconus and if the cataract is not significant, like Rohit showed, I will always try and do a cornea, maybe a DALC, or maybe if required, even a PK before doing the cataract surgery, because I think that's where you get the most predictable and also the most accurate results. In a case where you're doing cataract surgery with keratoconus, I think very little is known from literature. In fact, we published a paper in IJO detailing what would be the right method. And it seems that the SRK2 formula, not taking any lens factor into consideration, probably is more reliable than the more modern formulas that are used for calculating IOL powers. About changing the refractive index of cornea, I think you're right in the early phase, but I think after a year or so, the effect on the demarcation line that you have with cross-linking tends to regress. So that probably would not be a major consideration for IOL power calculation.
Yes. Thank you.
Dr. Pooja, do you want to add anything here about topo-guided regularization? We have not done in our place, but I think you all have done, no, Dr. Pooja?
Yes, ma'am. We actually, off lately, we have moved to 90% of our patients, if the corneal thickness is good, they receive topo-guided treatment for before cross-linking in the same sitting. We do it because we have data for more than 8 to 9 years now since the time Sir has started doing. What we have noticed is that patients who have received topo-guided PRK with cross-linking and versus the manual cross-linking, the chances of progression
No,
are higher.
I'm not asking. No, I'm not asking the regular. I said prior to cataract surgery.
Definitely, ma'am. I believe that also. We believe that if the patient has not undergone a cross-linking before, then you can do a topo-guided regularization with cross-linking. But if the cross-linking has been done before, then I think we do not touch the eye. We do not do a repeat treatment.
So just one thing about cataract surgery, sometimes the visualization really gets distorted. When you're doing a phaco, you can't make out, where you have to chop and where you have to actually consume the fragment. So I think for those distortions, you have to keep putting the viscoelastic onto the cornea again and again, because that kind of nullifies those distortions. And people have even described, Dr. Christopher Rupano has described the use of a contact lens onto the cornea while doing phacoemulsification, so that those distortions are taken care of.
Yes, I think in LV Prasad they have done as
in fact, the patient's own contact lens that seems to give the best visualization. Sterilize it, put a blob of visco, and then the patient's own contact lens on the eye.
Yes, right. So, anything else anybody would like to add? Because some of the questions which were not covered, or shall I conclude?
One question about the limbal versus the corneal incisions. In keratoglobus, you need to be very careful because sometimes even the limbal incisions can tear. So it's better to be a little on the sterile side if it's a keratoglobus going for cataract surgery.
Yes.
You can end up with a cruciate tear, then you have to glue it and put a BCL, etc. So that's all.
And we should suture up these wounds also.
Yes.
Ma'am, do you always suture the wounds or only if it's required?
In keratoglobus, we should, I think.
Yeah, sometimes they have brittle cornea syndrome also, and then everything that you do tends to just tear up, especially the keratoglobus.
You can have a lot of cheese wiring with the cornea coming in pies in your hands. So the cornea is left best untouched and all incisions sutured. Suturing also sometimes burying the knot, that tension the cornea does not take and it cheese wires. So that also has to be kept in mind.
Yes. So I think much of the questions have been covered. So I'm going to conclude. It's going to be 9. And so thank you very much, all of you, very respected expert panel and a great set of speakers for making it such an interesting 2.5 hours for all of us. I'm sure our attendees would have gained a lot. And I would want to again, of course, thank my ARC team for always being there to back me up. And of course, a very wonderful moderator, which I had, and who, ensured that there was a lot more content which was brought in this particular webinar. And I would take this moment to thank Mr. Kripal and the AIOS admin for always being there, supporting us. Special thanks to Sai and Manjula from Numerotech for sending these mailers on and off so that we have a good attendance happening all the time. And our very special thanks are due to Sun Pharma for sponsoring all the PG update webinars in this last 1 year. And we continue to look forward to their support over the next year. And finally, most importantly, I think our thanks are due to attendees, because that is what keeps energizing me to come back again and again. And although there have been many topics which have come this far, Ectasia is the first time which has come, the second time in the last 2 years. That just tells us that so much ophthalmology has to offer. that we can still do newer topics and with small minor changes here and there. Thank you so much, one and all of you. Have a great evening, what is left of it.
Thank you so much, Dr. Chitra, for the honor of sharing the platform. And thank you so much to all the panelists and attendees for the privilege of their time. Thanks a lot.
Yes.
And thank you, Chitra. Thank you, Chitra and Radhika, both for doing a great show.
Yeah.
Thanks
Like
a lot,
always,
Dr. Rambuka.
Thanks, Manati. Thanks, Dr. Praveen. And Dr. Sudhir, I need to
Thank
see
you,
you
ma'am.
more often. You keep
Sure,
coming up with excuses. No excuses from you. Allowed. Thank you. Thank you,
Thank you.
Dr. Radhika. Thanks, Radhika. Bye.